whoever's running the Zoom, if you can please give me the host powers.
You should be all set now, Councilor Arroyo.
Perfect. Thank you.
You're welcome.
No sé si me puede oír porque no sé.
You're unmuted, Julia.
No, ese no es arroyo. Ese arroyo. Hola. My mom wants to say hi to you, but we haven't started, have we?
No te rías tanto, yo estoy pai.
Hi, Councilman His mom. No, we haven't started. We're beginning.
Hola, señora.
Oh, ahí está Kim también.
Ahí está la mía ahí.
Sí, ahí está Kim también. Pero...
No ve.
Guys, I can't see the so
Just a reminder that we're
I'm
live.
not excited. I don't know if you can see.
We'll be starting shortly. I just want to make sure we give a couple more minutes for folks to arrive, and then we'll start.
No, yo voy para arriba.
Okay, I think we have all of our key folks here now, so we can begin. My name is Ricardo Arroyo. I'm the District 5 City Councilor. I'm the chair of the Boston City Council Committee on Public Health. I'm joined by my colleagues, Councilor Flynn, Councilor Janey, Council President Janey, Councilor Mejia, Councilor Sabi George, Councilor Campbell, Councilor Flaherty, and Councilor Wu. This public hearing is being recorded and live streamed at boston.gov City Council TV. It'll be rebroadcast on Xfinity Channel 8, RCN Channel 82, and FiOS Channel 964. We will take public testimony at the end of this hearing. If you do wish to testify via video conference, please email Michelle A. Goldberg at boston.gov to sign up. When you are called, please state your name and affiliation, residence, and limit your comments to no more than 2 minutes to ensure that all comments can be heard. You may also submit written testimony by emailing ccc.health@boston.gov. Today's hearing is on docket 0931. It's an order for a hearing reviewing the city's Melnia Cast Mass Ave 2.0 plan in light of COVID-19. Our run of show today is going to be 2 panels. The first panel is going to be the administration and members affiliated with the administration. So Kim Tai, the Special Assistant to the Mayor's Office, will be conducting that presentation, but available for questions for the council to ask directly after that presentation will be Jen Tracy, the Director of the Mayor's Office of Recovery Services, Sergeant Peter Messina from the Street Outreach Unit at BPD, Barry Bach, who is the CEO of Boston Healthcare for the Homeless Program and also a member of the city's task force, Jim Hooley, who's the Chief of EMS, Rob Consalvo, a Senior Advisor at BPS, Devin Larkin from Recovery Services at the Boston Public Health Center, Jim Green, Assistant Director of Homelessness at the D&D, and Neil Doherty, the Special Assistant to the Mayor's Office. So they'll all be available for questions. I believe the opening presentation will be conducted by Kim Tai. Panel 2 will be Cassie Hurd, the Executive Director of Material Aid and Advocacy Program, Leo Beletsky, a professor at Northeastern University School of Law, Dan Hogan, who's a provider at the Carbon Square Health Center, and Jessica Gallagher, a staff attorney for the Committee for Public Counsel Services. And so with that, I'm going to open it up to my colleagues for a short opening, beginning with Council President Kim Janey.
Can you hear me okay?
Yes.
Can you hear me? Okay, great. Let me start by thanking you, Chairman Arroyo. I want to thank you for your partnership on this issue and for your leadership as chair of the Public Health Committee. I also want to give thanks to everyone on this panel for being here tonight, and my deepest gratitude to residents and business owners who are impacted by this issue every single day and who are committed to finding solutions to a very complex problem in our city. As someone who grew up and currently lives in and represents Roxbury and the South End neighborhoods, I constantly see the trauma the opioid epidemic has had. I hear the concerns from residents and from business owners on how this is impacting their quality of life. In fact, just earlier today, I led a safety walk with residents and business owners and churches and nonprofit leaders, along with city officials. And let me quickly thank my sister in service, Councilor Sabi George, who joined us, Neil from the Mayor's Office, who's here tonight, Kim Tai, Jen Tracy, and others on the team for being there. We walked all through Nubian Square and along Washington Street. We walked all the way down to Mass Ave and ended up in Chester Park in the South End. And in Nubian Square, and we spent a significant amount of time there. People know that people who live there, predominantly people of color, businesses of color, poor people of color, and they're already vulnerable due to just trauma and the long history of racism, systemic racism in our city and in our nation. And now with this widespread open drug use and among many other things that people usually do in the privacy of their homes, unfortunately, people are seeing all kinds of things. And we heard on the walk today, everything ranging from sexual acts to feces to needles. And this is compounding the trauma that's already there in this community. And no one should have to see what residents and business owners described on this walk or what people have called my office, and I'm sure other city council offices or 311, and what they're describing. No one should have to see this on a day-to-day basis, and no one should have to live like this. Not the residents, not the business owners, and not the people who are homeless or who have substance abuse disorder or mental health issues. No one should have to live like this. And so as we discuss this issue, it's important that we all remember that we're talking about people in our city who are ill and who are in need of support and services. They are often vilified in these discussions. Connecting people to the services and long-term recovery takes a lot of work, and it doesn't happen overnight. And even when we see a particular area that looks like it's been cleaned up or people have called and maybe the issue or problem has moved somewhere else. And so it's really a long-term solution that we are seeking here, as well as some immediate things that we can do now. And so while we recognize people's humanity, as we discuss this issue, it's also important that we acknowledge our own history in this country. We know now that there are more Black men currently in jail or in our prison system now than were enslaved in 1850. The war on drugs was used to further criminalize Black people. Addiction for poor people, particularly poor Black people who were using crack, that meant jail, while addiction for white residents, many of whom are not from Boston, but are from surrounding communities, it's now viewed as a public health issue. And it is a public health issue. This is not a criminal justice issue. This is a public health issue. The towns surrounding Boston, they must step up and deliver needed services to their own residents. Too much of this burden has fallen to Boston for far too long, and too much of that burden within Boston is falling upon the shoulders of Roxbury and the South End. We need to decentralize treatment opportunities so that they are not clustered in one part of the city. Addiction knows no neighborhood boundary. And so we shouldn't have our treatment clustered. And when we do cluster it, it makes it easier for drug dealers and others who would prey upon people who are already vulnerable. We are now a year in since Mayor Walsh announced Melnia 2.0. And so a lot has happened in this last year. It's been a very eventful year. And I think it's the perfect opportunity to check in, to see what's working, to see what's not working, to see what can be improved. And I'm hoping that this will be a very productive, solution-oriented conversation that will help advance this work. Thank you again, Mr. Chair, and to all my colleagues who are joining in this important discussion.
Thank you, Madam President. I'm now going to go in order of arrival to the other counselors. If you would like to make a short, no longer than 2-minute opening, and I'll save mine for last. I just want to make sure I have that order here now. 1 second. Councillor Flynn, if you can start, followed by Councillor Mejia, followed by Councillor Sabi George. And I'd like to acknowledge that Councillor Baker has joined us.
Thank you. Thank you, Mr. Chairman, and thank you for your work. I want to say thank you to Councillor Janey as well. I know the COVID, this pandemic has made the work that we're all doing very difficult, as programs and shelters had to readjust their services in the challenges. And we have seen many cities and towns across Massachusetts really shut down their social services. And what happened then is Boston became the provider of social services across the state. So as Councillor Janey said, it's important that cities and in towns across Massachusetts get off the sidelines and start doing their part, especially those wealthy communities such as Wellesley. We need more social services across the state. I'm a member of the MassCast task force, and this group meets frequently to discuss issues, but are also planning for the future and concerns to develop a system for everyone in the area, residents in Roxbury, the South End, which I represent along with Councillor Janey, Councillor Baker, and South Boston has been hit it has been impacted as well. Andrew Station is the closest MBTA stop to Mass Ave and Albany Street area. Substance use disorders is a citywide issue. It's a statewide issue. And it's important for all of us as councilors to be involved in this work, to work together. My vantage point as a District 2 council, I've seen improvements around Mass Ave with hotspots in my district as well. The work isn't easy. It's very difficult. I've worked on this issue as a probation officer for 10 years prior to working on the council. It's not going to be solved overnight. It requires all of us to work collectively to support our city workers, our state workers that are out there doing the job. Again, I want to highlight the city and the programs that they're offering. They're out there day and night working to get people into recovery. It's demanding, it's difficult. So I want to acknowledge their work. And I see my good friend there, Chief Hooley. I don't think there's a better city employee in the city than Chief Hooley. He's been working on homeless issues for 40 years, as Jim Green has. So between the two of them, there's probably 80 years of experience working on recovery and homelessness issues. And that's invaluable service we have in the city of Boston. But again, just want to say thank you to Councilor Arroyo and to Councilor Janey as well. Looking forward to working with everybody and learning more. Thank you.
Thank you, Councilor Flynn. And just so folks understand, we have a pretty deep public comment group today. We've received over, at least at last count, about 20 plus written comments. And so if folks can keep the opening short so that we can get through to the panel, which is pretty large, and then give them a time to speak, hopefully within a reasonable hour. And so Councilor Mejia.
Thank you for that, Councilor Arroyo. Already putting me on notice that I need to keep my comments short. I see you. So anyways, really quick, I want to thank the sponsors for calling this hearing. It's really important. I recently attended the South End Roxbury Community Partnership meeting a couple of weeks ago, and a lot of questions came up. And one thing that was really clear to me is that those who are living the realities and doing the work really want to be heard and have a lot of great ideas and solutions and ways that they can address this problem. And so really looking forward to hearing from these voices and creating space for them to be working in partnership with the city to address these concerns. And you're right, Councilor Flynn, it's going to take all of us working in every corner of the city, because what I also see is that oftentimes the issues that are impacting Roxbury, Dorchester, Mattapan, you know, we tend to see our issues really siloed in areas that we are either working in or neighborhoods that we represent. But when it comes to Mass and Cass, I believe this is something that we can all, the entire council could really dive into and recognize that we all need to be held accountable to this issue. And so a lot of the questions that I've heard is, who are the members of the task force? I'm curious about accountability in terms of how we're utilizing the funding that is going towards addressing these issues and what's our return on investment. Really looking at ways that communities can be more engaged in this conversation. So I'm here to listen and to learn and to be in partnership. I know that as the chair of small business, the businesses in the surrounding area have also been hit hard. And so really looking forward to having a robust conversation. I'll be in and out, but I'll be here to listen to a lot of the advocates who are going to be speaking later on tonight. And then Councilor Arroyo, I did get a text message from someone who's slated to speak. Her name is Jada Rackert. They haven't received any notice as to whether or not they're going to be part of the testimonies, public testimony. So I'm not sure if you see her on your list of attendees, but Jada is a teenager and is slated to speak. Jada Rackert. So I just want to make.
She's on the list of attendees. I see her.
Okay,
We'll make sure she gets her time to speak.
Okay, great. So let that be known. She just wanted to
Thank you.
make sure of that. Thank you so much.
Councilor Asabi George.
Thank you, Mr. Chair, and thank you to everyone who's here today and who's been in this work for so long. I think that it's really important to note that this is a collaborative effort. We need to be able to cooperate and coordinate our work and services across the board. And since joining the council I've been living a lot of this work most of my days and most of my time on the council, and through that effort had been bringing together many of our state partners and our nonprofit partners into this work. Want to make note that this meeting today is about Mass and Cass, but this really is a citywide issue. When we see the impacts of the opioid addiction crisis, we see the impacts of mental health or a lack of mental health services, and the increasing impact of homelessness on our city, across our city. So it's certainly about the work that's happening here. It's the work that's happening at the state level. It's the work and the impact that's happening or not happening in the greater region. And when we think about the impacts on our city and in our neighborhoods, and in particular Mass and Cass, as Council President Janey mentioned, this is a national issue. When 60% plus of individuals seeking services in our cities are from other places, we have a problem, and we need to get to work to not just support those individuals, but to make sure that we have a focus on decentralizing services when it comes to what's happening in our neighborhoods, but also improving the quality of services and doing that in partnership with other organizations. I've been sort of mocked over the years for asking for reimbursements from other places when we think about the services that are provided in our city, but we need to do that. It's certainly about improving access to detox programs, to recovery programs, to sort of mid and long-term, but lifetime programs, because we know recovery is only found through a lifetime of effort. So look forward to this work, look forward to the continuation of this work, identifying where so many of the gaps still exist, and how do we better improve the quality of life for our businesses, for our residents, and for those that are suffering from the ills and the chaos and the crisis that homelessness, that mental health issues and substance use disorders bring to our community. So excited to be here, excited to hear from the panels, the number of panels, and sort of those with living this every single day. Thank you, Mr. Chair.
Thank you, Councilor Savi-George. I just want to note that Councilor O'Malley has joined us. The next three in order will be Councilor Campbell, Councilor Flaherty, and Councilor Wu.
Thank you, Councilor Arroyo, and thank you, of course, Council President Janey, for your partnership in this important hearing. I recently did a walkthrough, I guess it wasn't so recent, maybe a couple of months ago now, in the neighborhood in which I grew up. I often go back and it's nostalgic and it feels good, but lately it's incredibly painful to drive through there or walk through there and see what's happening. I have to give kudos, of course, to the residents, the civic organizations, and the organizations on the ground and the businesses who have been putting forth specific solutions for some time. We have great plans. We have, we want to rebuild Long Island Bridge. Yes, let's do that. It's incredibly important. The plans that the mayor and the administration and the task force have are great. Many of those are long-term. And so most organizations, most people, and most residents need short-term solutions. After my walkthrough, I sent a letter just lifting those ideas up, including decentralization of services and the need for the city to take the lead on that, as well as short-term solutions around sanitation and housing those who are homeless. If we were able to do it for folks in the midst of the pandemic, we can obviously do it in the midst of this opioid crisis in a more timely manner. And then lastly, I'll just say, we have to do a better job calling out the state and Governor Baker specifically. I've worked in partnership with the administration, including Governor Baker and others, on some prisoners issues, things around the Department of Correction. But at times, we don't always agree, and this is one of them. If for us to be successful in short-term solutions and long-term solutions, other municipalities are going to have to step up. They need to share with us their specific plans as to how they're helping the city of Boston address these issues, since we are servicing many of their residents. And I think there's a way to do that in partnership with our surrounding municipalities. And if they're unwilling to share their plans, then the state really needs to step in and mandate some of this, but the hands-off approach is not working. So thank you both for your leadership here, this timely conversation. Thank you to all of the panelists, the task force members, and the administration for the hard work. I appreciate their dedication too. Thank you, Councilor Arroyo.
Thank you, Councilor Campbell. Councilor Flaherty.
Thank you, Mr. Chairman. Hopefully you can hear me clearly. Thank you for chairing this very important hearing, and also thanks to the members of the administration and the many stakeholders doing the work each and every day in that area, especially our public health workers, EMS, our police, and best clinicians, and many of the civic organizations and business
You cut out there, Councilor Flaherty. Okay, well, that gets sorted out. Councilor Wu.
Thank you, Mr. Chair, and thank you so much to the co-sponsor of this as well. This is not only citywide issue, but also incredibly urgent and made even more so for all the reasons that others have outlined during this pandemic. I just want to plant some questions here because I know so much of the opening, I ditto to what all my colleagues have said. And just for my part, to help frame the conversation, I would really love to hear from the administration and the city on what is the citywide plan as it relates to the opioid crisis and folks experiencing homelessness. This is only going to grow and grow during this pandemic. And while we might see Mass and Cast 2.0, update on Mass and Cast 2.0, the plans are never grounded in more than an effort to sort of push on the public works side and, amazing efforts by our city employees to, increase the response or decrease the response time and make sure we're, following all of the constituent requests that come in, but we will never solve this issue. We will never get to a livable, sustainable quality of life for anyone, a safe experience for anyone in the area, residents and businesses and patients in that area, unless we are focusing on the underlying public health and housing issues. So I just want to flag my frustration in this conversation and the sense of urgency that I think during this pandemic, we should take as an opportunity to really rethink and reimagine our systems and move forward with citywide responsibility and take action rather than just sort of waiting for others across the state to step up. Thank you so much, Mr. Chair.
Thank you, Councilor Wu. Councilor Baker.
Thank you. I'm here tonight. I just want to, first of all, thank all the people that have been doing this work. I'm on my screen. I'm looking at Kim and Jerry and Jen and Jim Green and Sheila Dillon, Jim Hooley, all these people that have been working for years towards this problem. And it seems, I don't know, sometimes like it's just getting worse. I don't really know what's going on. I think we have the weather on our side lately because it seems like it's been somewhat quiet, but we have to, like a lot of the previous speakers said, we have to lock arms on this and figure out how it happens together. I think there are some things that we can be doing, should be doing that maybe will be unpopular with, I'm sure, a lot of people on this call, but here to listen to see what's going on in particular, with 2.0, with the encampment protocol and different things like that. So thank you for the time. Thank you.
Thank you, Councilor Baker. Councilor O'Malley.
Thank you very much. Thank you to the chairs for their work on this incredibly important issue. I don't need to tell the people on the Zoom call that the pandemic has exacerbated so many issues that we are dealing with as a city. Certainly that is the case as it relates to those who are suffering from addiction, those who are not receiving the services that they desperately need for mental health, substance abuse, the dual diagnosis, and those who are unhoused, those who are having such a difficult time as the weather does get colder. That's an added level of pressure that has certainly been brought to bear. So I'm looking forward to seeing the work that we've done, seeing ways that we can truly address so many of these myriad issues going forward, looking at best practices. Councilor Baker, Councilor Sabi George, and I have spent some time in Vancouver and Toronto, along with Chief Hooley, some of his colleagues, men and women of Boston EMS, who've done some remarkable work, incredibly hard work here, looking at best practices from other cities as well. So there's no shortage and there's no monopoly, certainly, on good ideas. This is an incredibly this is just such an important issue that we need to be dealing with. We need to be working together. We need to be able to help those individuals who are suffering. So I look forward to continuing to work together. And thank you all for being here to discuss this incredibly important topic tonight.
Thank you, Councilor O'Malley. I believe Councilor Flaherty has his connection back. Councilor Flaherty, if you'd like to finish your opening.
Thank you, Mr. Chairman. Yeah, just briefly, obviously, our residents and our businesses deserve to feel safe walking around their neighborhood, and our children and youth sports league deserve to play on fields free of fear of finding or stepping on needles. So we really need to redouble our efforts, find solutions, and hopefully this hearing will help move us in the right direction. Thank you, Mr. Chairman, for your patience.
Thank you, Councilor Flaherty. And I'll just say a few things before we get to the panel here. Before I was a counselor, actually, this time last year, I was a public defender, and I was representing folks in Roxbury and Dorchester district courts, and that included clients who resided on Melnia and Mass Ave. And, you know, one of the things that I know and I believe, and I think all the data shows, is that we're not going to arrest our way out of this. We're certainly not going to section our way out of this. What I experienced working with clients who suffered from substance use disorder was that they really needed access to treatment. And most of the time that treatment wasn't readily available. So if we wanted to get them treatment, a treatment bed, it would take months. In some cases, to speed that process up, they would have to go voluntarily to a detox center where they would wait months there if we had the ability to do that. And so, you know, there's a shortage, frankly, of resources. And I'm very interested in this panel and hearing, you know, what we're doing to address that shortage, because, you know, I think one of the things that I'll speak for myself on is we hear often about the region needs to step up, which I agree, that we need more access and use here in terms of access to treatment and use of resources to deal with this issue, and that the region should be kicking in, neighboring areas should be kicking in, and that folks who are on Mass Ave and Melnia Cass aren't part of our communities. And the reality is they're here now. And the ways in which we seek to help them has to be rooted in seeing them as community members, and also understanding, and this is the balance, understanding that there are community members there who deserve to have parks that don't have needles, that deserve to be in a place that's safe for their children. And so, you know, I think this is obviously a complicated issue. The reality is I would agree with Councilor Baker. I don't think I've seen, at least visually, what would appear to be any steps forward. And I'm very interested in seeing how we get there moving forward. And so with that, I'm going to pass this over to a presentation by Kim Tai. And then I know that some of my counselors weren't here for the very beginning, but there's a number of people here from the administration to answer questions. So after her presentation, I'll say the list of folks that we have here to have asked for questions, if you have questions for anybody. And then we'll go again by order of arrival. So with that, Ms. Tai, the floor is yours.
Thank you, Councilor Arroyo and Council President Janey, for calling this meeting. If I may, if I can share my screen for the presentation for my portion, Councilor?
Yes, please do.
Okay, thank you. Thank you again, Council, for calling this meeting and asking the administration to give an update with respect to the MassCast 2.0 plan. And thank you for your opening remarks. I think that everyone acknowledges and recognizes that the challenges of homelessness, substance abuse, and mental health are very serious challenges that not only the city of Boston faces, but large municipalities across the country face, particularly in the West Coast. But we're here tonight just to give a brief overview with respect to the MassCast 2.0 plan. It's been a year since Mayor Walsh created that plan in October of 2019, where we are now, given the pandemic, and then where we're headed as well. So Mayor Walsh, again, created the MassCast 2.0 plan in October of 2019, recognizing the impact of the opioid epidemic and homelessness, particularly in the Mass Ave and Melnia Cass area. And again, we recognize that the Mass Cass area is the epicenter of these challenges, but that these issues do impact neighborhoods across the city. And I would argue that the MassCast 2.0 plan is a plan. It is a framework by which the city agencies are trying to move forward to resolve these challenging issues. And it allows us to focus our efforts on the coordination and alignment of services while still prioritizing our initiatives under the categories of public health, public safety, and quality of life. Because these challenges are ever evolving, and I think that we witnessed that particularly during the pandemic. It's incredibly important to find the balance between these issues because it can't be resolved with just one approach. I think we can also agree that if there was an answer to these challenges and these issues, that every other city as well as ourselves would be moving forward with that answer. And at the same time, while we're working on these plans on day-to-day operations, the city and its partners continue to focus on providing more permanent affordable housing and other long-term strategies. In the past year, most notably, the mayor dedicated additional services to the area to include more outreach recovery coaches, a dedicated DPW team, and the creation of the Boston Police Street Outreach Unit. It's also important to recognize that many city agencies were already providing services and outreach in the area, but we focused on the coordination and alignment of those efforts to ensure a more efficient and effective strategy. More recently, BPHC also created a new pilot program to pick up human waste on private property through 311, and the BPD Street Outreach Unit is moving into the Kramer building located at Mass Ave and Albany Street as a first step towards creating an operations command center focused on public safety. As everyone knows, COVID epidemic had a significant impact on our efforts in the Mass Cass area. And very quickly, we had to create safe spaces for unsheltered individuals who tested positive or needed to quarantine. Our shelters worked diligently to ensure sufficient social distancing, while our recovery services departments worked to provide services outside. And our efforts towards addressing the challenges of homelessness, substance abuse, and mental health issues never stopped during this time, but the pandemic exacerbated the situation. The social workers, street outreach workers, first responders, public safety officers, and recovery coaches have been working harder than ever. So one of the initiatives that we were able to create was a website that demonstrates the daily efforts of the coordinated response team. And I'll go a little bit further into the details of the coordinated response team and who comprises that group. This website at boston.gov/mass-cass links each coordinated response team department webpage for more details and information that you'll also be hearing about tonight as well. And it was important for us to publish a website that's dedicated to Mass and Cass that provides real-time data and metrics. It features a dashboard with the metrics of the work that's dedicated to a 3/4 mile radius around Mass Ave and Melnia Cass. And it features monthly and year-to-date numbers for public health treatment placements, EMS Squad 80 incidents, permanently housed shelter guests, BPD street outreach interactions, and a syringe rate return. And we'll continue to expand on the metrics with data from new initiatives and efforts as we move forward. It also gives us the opportunity to post updates and changes in real time. And in addition, there is a neighborhood map that identifies city and state properties along with resources in the area. It's also important to check back on our website for updates. Again, we've included the details of the 2.0 plan and most recent progress report to talk about all the incredible initiatives and programming that we've done in all of our departments. So the coordinated response team was created through the Mass Cass 2.0 plan. And it's composed of the following departments of the Office of Health and Human Services, the Public Health Commission, the Boston Police Department, Inspectional Services, Emergency Medical Services, Boston Fire Department, Parks Department, the Office of Neighborhood Services, Department of Neighborhood Development, Department of Public Works, Office of New Urban Mechanics, Boston Public Schools, and Recovery Services. And these departments deal directly with the challenges of homelessness, substance abuse, and mental health. And the coordination and the communication between these departments is unprecedented. We meet daily to address day-to-day operations and weekly to strategize and implement longer-term planning. We created an unsheltered persons category within 311 that sends complaints directly to the CRT team so that we can coordinate our responses to ensure that we respond efficiently while still providing quality of care and connecting people to services. An example of this alignment of services is how we've approached encampments with the same lens of quality of care and focus on public health. Recovery services, ISD, BPHC, BPD, BFD, DPW, Parks, and our partners at Pine Street Inn all work together to ensure the balance between the cleanliness of public spaces while offering treatment and shelter to those who need it. Another example is the post-overdose response team that is comprised of the recovery services, EMS, BFD, and BPD, which automated follow-up engagement with individuals who've experienced an opioid overdose and offered treatment and services. This team has visited 478 addresses since its inception, and these coordinated efforts are the types of programs and concerted efforts that our departments offer in addition to the normal services these agencies provide on a day-to-day basis. In addition, this summer, the coordinated response team met with neighborhood groups and individual businesses to address concerns and help address issues with in areas including Peters Park, Nubian Square, Worcester Square, Andrews Square, Southwest Corridor, North Station, and New Market Square. And although the coordinated response team is an internal city team, we do partner with other agencies when it's appropriate, such as the MBTA and DCR, along with other state agencies. So with respect to the pandemic, it radically changed the availability of emergency shelter beds. And in the beginning of the pandemic, we lost about 554 beds, or about 33%. What we do have for beds pre-COVID was 1,627 beds, and post-COVID was 1,083 beds. And we average a current capacity of about 90%. The winter planning team currently has approximately 190 new beds throughout the city outside the Mass Cass area. And we're also working with the state to set up other sites outside of Boston. And in addition to that, we're also looking at how we can reduce inappropriate discharges from other systems of care into the city of Boston. We are also concerned about colder weather and properly sheltering those who are experiencing homelessness. And so again, we are meeting with the state with respect to that. Regular COVID testing results have been very good in the last round at 2.8% at 112 and less than 1% at 1515 in Woods Mullen. Again, our shelters did not close during the pandemic, and we are open 24/7. We see about 5,000 new guests each year who display a range of different issues from mental health, substance abuse disorders, disabilities, and poverty. And again, our capacity was lowered at 112 Southampton and Woods Mullen during the pandemic, but it was offset with additional beds at 1515 and 891. With respect to housing, Boston's homelessness has been an incredible part of our longer term strategy. And Mayor Walsh, through Boston's Way Home, to address chronically homeless, as well as the vets, have been able to house over 2,300 people since its inception, since 2014. In addition, the mayor launched Boston's Rising to Challenge plan last year to address homelessness among our youth. And again, that's to focus on our young adults who are unable to be serviced within our own shelters. During COVID, we'd be remiss not to say that there was a slowdown with respect to housing performances, but however, we've been able to get back on track. And since then, we've identified about 558 new supportive housing units that are going to be coming online. Also, it's important to mention that between now and March of 21, we plan to permanently place 135 individuals. So one of the programs and initiatives that came out of the pandemic were the comfort stations. And we set up comfort stations to provide hand washing and bathroom access. During the pandemic, private and public buildings closed, as well as a lot of facilities and day resources for unsheltered individuals. And then public bathrooms became a real issue. and public health is a priority on a daily basis within the Comfort Station on Atkinson Street. It's also an opportunity for us to connect with individuals with services. Our overdose reversals save lives and we provide EMS resources. We have nurses that provide oversight, and the station hosts wound care sessions for abscesses and infections. Our staff from the Engagement Center and PATHS help individuals connect to detox and treatment placements, including on-demand access to buprenorphine induction. We hand out more than 200 clean masks every day on demand, in addition to access to COVID screening and testing. And in addition to that, we also provide on-demand access to HIV, STI testing, and the initiation of PrEP. The Office of Recovery Services is also promoting the decentralization of services to ensure that people with substance abuse disorders receive access to quality of care in any neighborhood, city, or town where they live. And this graphic shows you some of the providers that are providing harm reduction throughout the city of Boston and not just within Mass and Cass. And as you can see, there's a number of agencies that also provide mobile services, which were increased during the pandemic. Expansion of the harm reduction services, which include syringe services, STI, HIV testing, overdose prevention, supported referrals to medical care and treatment, includes the AHO program, the Care Zone mobile van, Project Trust, BMC, Fenway Action, and Victory programs. And these services are available in Mass Cass, Roxbury, Downtown, Jamaica Plain, Dorchester, and Fenway. BPHC is also working with community health centers across Boston to support increased training and programming. So with respect to public safety, and I mentioned this before, the Mayor Walsh created the BPD Street Outreach Unit. And the mission of the Street Outreach Unit is to promote community-based outreach to those who are affected by mental illness, substance abuse disorder, and/or homelessness. And they work with their partner agencies to connect individuals to services before they engage in criminal activity or reach a crisis. And through daily collaboration with their partner agencies, they conduct outreach in the Mass Cass area, including Ramsey Park, Washington Street, and Milne and Boulevard, and Nubian Square. Strategic collaboration not only reduces criminal activity through diversion to treatment, but also allows us the opportunity to identify and address the root causes of criminal behavior. In addition to the partnerships and collaborations, members of the unit are trained recovery coaches, are involved in training to certify new recovery coaches, and developed and respond to a BPD outreach hotline where new clients are referred. Co-respond with best clinicians for calls that require psychiatric crisis services, and partner with PARI, which is the Police Assisted Addiction and Recovery Initiative, to increase the BPD's recovery coach capacity and implement Section 35 commitments as a last resort to those in need. And looking into the future, they're also working to organize a Mass and Cass hub, which will be a weekly collaboration to discuss plans for high utilizers of services in the Mass and Cass area. And in addition, BPD Street Outreach Team is in the process of hiring 14 additional best clinicians. Since last year, these are some numbers that may be of interest to the council. They've had a total of 1,494 outreach encounters, 131 Section 12 placements, 9 permanent housing placements, 124 voluntary substance abuse placements, and 64 Section 35 placements. There's a continued balance between recovery and in law enforcement, and the BPD Street Outreach Team is also coordinating with the DA's office to continue diversion efforts to get more people into treatment and working with the courts so more work can be done through remote teleconferencing. In addition to the BPD Street Outreach Team, we also have 3 other public safety departments that work in the Mass and Cass area. We have the Inspectional Services I&E Team, which is the investigative and enforcement team, which usually makes their initial contacts with encampments. And the I&E team is comprised of ISD inspectors, BPHC, as well as BFD. They are constantly monitoring the 311 complaints and receive referrals from the coordinated response team on locations that need to be assessed. And during their initial visits. They gather information, post sign for cleanup, and partner with the outreach team for BPD and Pine Street Inn to make referrals for services if needed. And they also coordinate with the other departments, including Parks, DPW, MBTA, DCR, to schedule cleanups. In addition, EMS formed a non-transport unit in 2017 known as Squad 80 to respond to calls in high-impact drug overdose areas of the city. And in 2019, it expanded to 7 days a week. In 2019, Squad 80 responded to 2,589 incidents and made 383 shelter and recovery service referrals. And in 2020, Squad 80 launched the Leave Behind Narcan program. Our Boston Fire Department recovery coaches also support overdose prevention, response, and recovery. And in the past year, the fire department partnered with BPHC's PATHS program to get individuals into detox treatment and rolled out the Delta 21 Alternative Response Pilot and supported Noxolin access and training. And then finally, under our third bucket and category with quality of life, our Department of Public Works, and here you can see some photos of our DPW crews cleaning up last week. So 3 times a day, 7 days a week, our DPW crews are out in Mass and Cass area. Day shifts have mechanical sweepers and hand crews, and the second shift is hand crews along Mass Ave into Worcester Square and Springfield and down toward Melnia and Thorndike and Reed Street as well. And the third shift is mechanical sweepers. They clean the connector at Mass Ave with a BPD presence 5 days a week and whenever requested on the weekend. In addition, Pearson, Pompey, and Allerton are 2 times a week with hand crews and sweepers after trash day, and additional routes now on Camden to Columbus. The Mass Cast 2.0 plan did dedicate a Mass Cast team under DPW, but in addition to that, it's been supplemented by 2 more employees and now is at 7 days a week rather than the initial 4 days a week before. Nubian Square is also cleaned Monday through Friday at 6:15 a.m. by 6 crew members and a mechanical sweeper, and that's from Melnia to Dudley on Washington and Warren, as well as a municipal lot. I think Councilor Wu did mention that DPW has done a phenomenal job and its constant adaptation and response to what's happening in the street, particularly during the summer. They dedicated more crews to cleaning up in the area. In addition to our quality of life, Boston Public Schools is a key member of our coordinated response team. And again, you can see some pictures that were taken last week of Ramsey Park as well as Melnia Cass Boulevard. Boston Public Schools has worked proactively to address operation issues to protect the safety of students, teachers, staff, and visitors. And while we work diligently at all of our schools, we have focused our efforts on the schools most impacted by the opioid crisis. They include Orchard Gardens, Mason, McKinley, Josiah Quincy, Trotter, and the O'Brien complex. Our operational efforts have included installing fencing to stop trespassing on school grounds, installed additional cameras and lighting at schools as an added safety measure. Custodians sweep their school properties at regularly scheduled times. And every Monday morning, citywide custodial ground crews start at the day at the Orchard Gardens, Trotter, O'Brien, Madison Park, Mason, to assist the building's custodial staff with cleaning and inspection of the grounds. The Parks Department assists the BPS teams when they're conducting routine maintenance of adjacent parks. And the custodial staff have been trained on needle pickup by the Mobile Sharps team. And we've also trained additional school faculty and staff. BPS transportation officials located at Washington Street Bus Yard at the intersection of Washington Street and Melnia Cass Boulevard have also received Sharps disposal training. And in addition to that, BPS has begun planning a Safe Corridors to School pilot program with the Orchard Gardens School Leadership Team as part of a community-wide effort to further ensure that Orchard Gardens students have safe options to walk to and from school during the school year. And we hope to launch the pilot program when school safely resumes based on the data and science with advice and guidance from BPHC, Chief Martinez, and other public health experts. Just to touch briefly on Long Island, while we recognize that opening the recovery campus at Long Island is not going to solve all of the issues with Mass and Cass, we do recognize that it is an incredibly important initiative and long-term strategy with respect to creating a recovery campus. And while we are in litigation currently with the city of Quincy, we want to recognize and acknowledge that there's been a lot of planning that has still been ongoing and between the programming from the recovery services and BPHC departments, but also looking at capital assessments of the buildings and structures on the island. So just again, just to reiterate that Long Island, we are still planning in the planning efforts and have made a lot of strides despite the litigation that we're still under right now. And again, here's some recent pictures in the last week of the connector at Mass Cass, as well as along Mass Ave and Albany Street. And it's at this point, you know, we want to recognize that the issues of homelessness, substance abuse disorder, and mental health are incredibly complex. And that's why we approach these challenges with different strategies and different initiatives. But we continue to work with our partner agencies, including the state and other cities, to try to decentralize services outside of the Mass Cass area and also outside the city of Boston. And while we have made some successes and strides within the last year, we do recognize that we were slowed down during the pandemic. And we also recognize that there's still a lot of work to be done. However, that isn't to say that the 2.0 plan isn't a plan. It's a framework by which we respond as well as proactively engage in terms of strategizing on day-to-day operations, but also our longer-term planning as well. One thing I do want to point out, because I do know that there's a question with respect to, I apologize, here's some more pictures of the Mass Cass area. There's a question with respect to the task force, and it has been brought up here in a couple of the councilors' opening statements. So the Mass Cass task force was also created within the 2.0 plan, and some of our councilors here tonight are on the task force. Councilor Baker, Councilor Asabi George, and Councilor Flynn are representatives on our task force. It is a mix of elected officials, so we do have State Rep Miranda as well as Rep Santiago representing Roxbury and the South End. But we also have civic leaders as well as service providers and institutions in the Mass Cass area. So you can see this is an incredibly diverse group of people and perspectives who all bring different expertise to be able to have real discussions about what type of innovative ideas that we can bring to the table to try to address some of these challenges. And one thing that's important, you know, while the task force does meet monthly, we recently broke out into working groups. So there's two working groups, the advocacy working group, as well as the quality of life working groups. And these working groups meet every 2 weeks. And they're just smaller committees within the task force. And these are some of the topics as a group that we've been addressing. And as you notice, we look at Long Island, Shattuck, supportive housing, methadone waiver legislation, public bathrooms, decentralization of services, planning studies, and encampments. All of these topics touch on day-to-day issues as well as long-term strategies. So that concludes our presentation, and thank you again, Council, for having us here.
Thank you so much. And now I'm just going to run through the list of folks, including Ms. Ty, who are here for questions during this period from my council colleagues. We have Jen Tracy, who's the director at the Mayor's Office of Recovery Services, Sergeant Peter Messina from the Street Outreach Unit at BPD, Barry Bach, who's the CEO of Boston Healthcare for the Homeless Program. He's also a member of the city's task force. Jim Hooley, who's the chief at EMS, Rob Consalvo, the senior advisor at BPS, Devin Larkin from Recovery Services at the Boston Public Health Commission, Jim Green, the assistant director of homelessness at D&D, and Neil Doherty, special assistant to the mayor's office, are all here to answer questions. And so for my council colleagues, you can direct your questions directly to any of them, or I guess you can just ask it, and whoever feels best equipped to answer it can take it. And with that, I'm going to hand it off to Council President Janey, who will be followed by Councilor Flynn and Councilor Mejia.
Thank you, so much, and thank you for that presentation. Thank you again to the panel and to all those who are tuning in. One thing I'm trying to walk away with understanding is understanding whether or not we're able to quantify the problem. I saw some of the slides in the slide deck that had numbers and percentages in terms of numbers of encounters. I'm wondering, and I know it's probably impossible to count, but I'm wondering if we have a way of measuring like how many individuals we're talking about when we're talking about this issue.
Yes, Counselor. And I think I referenced it initially in the beginning. So on our website, we do have a dashboard. And on that dashboard, it does give you metrics that are split up between public health and public safety in terms of the number of interactions that we have on a monthly basis, as well as year to date.
So just to clarify, it's not so much the interactions, and I do want to kind of go into the interactions and understand the engagements and where they lead. I think those are very important, but it's trying to measure just the problem outright. So there may not be a way to understand what that denominator is, but that's what I'm trying to understand. If I don't know if any of the street teams are taking counts. I don't know if once you're engaging with folks, and I hope that you're able to get whatever information people are willing to volunteer so that you then now have a database to say, okay, we've got these people. But I'm trying to just measure the overall. Are people counting folks? Is there a way once you do engage with them, we have a good count, but we can't really count it if they don't engage?
I think, so yes, every outreach team does count their engagement and interactions, and that's where we're getting our numbers from.
Yep.
So the
And
numbers
so
that
I'm
I'm
not talking
talking
about counting the engagements. I'm just talking about the number of people. So there could be 1,000 people, but your team can only engage with 100 people. So that I'm trying to understand what that larger number is. And we may not know that, and that's fine.
Mm-hmm.
It might be too difficult to try to measure that. So let's just start with the engagements then.
Counselor, I apologize. We do a yearly homeless census.
Okay,
so that
maybe
does give us a general number. And I believe Jim Green is on the panel, and maybe he can speak to how the homeless census works as well.
Yep, and as you do, Mr. Green, just I want to be clear, and I know colleagues often point this out. It's important not to conflate. So not everyone, when we do that homeless census, are going to be people who are struggling with substance abuse disorder. So I'm happy to kind of understand the homeless numbers, but I'm really trying to understand where the intersections are, where people are homeless and have addiction issues and are out on the street. And we're trying to connect them as a city to services for treatment as well as shelter.
Yeah, so I think that you're correct, because like when we talk about mass incarceration challenges, it's homelessness, substance abuse disorder, and mental health. And when you're talking about that population, it can be an individual that has all that qualifies for all three, or maybe 2 out of 3, right? So in addition to Jim Green, we do have Jen Tracy and Devin Larkin from Recovery Services who do the Recovery Services engagement. And then we also have Sergeant Peter Messina from the BPD Street Outreach team that does engagement as well. So I believe any of those 3 people could talk about their component of outreach engagement.
And since, and let me ask some questions about just the touches and the engagement and where that leads, because I think it's probably too difficult to just understand what the overall number is. There was that one slide deck in the presentation. I thought it was helpful. I think it was a period of time and there were 1494 engagements.
Yes, that was the BPD Street Outreach team.
Yes, and which is great. I'm looking at the overall engagements that included the Section 12 and the Section 35s, and see that people, if you look at that number, it's roughly about 15% of people who have been placed somewhere. And if we take out the sections of where people are voluntarily seeking shelter and treatment, the number drops significantly to about 9%. Is that something, this is a number that you plan on continuing to watch so that we can measure this over time? Do you have any measures over time that we can look at in the past year where we see it on a graph on how those numbers have gone up and down in terms of the engagements and where people are getting placed?
So just to better understand your question, so the numbers that we were showing for the BPD street outreach has been over the course of a year. So you're looking for just a graph like per month, or?
So no, that's fine then. If it's over the course of a year, I thought it was from August on. I don't have it up on my screen.
Yeah, August 2019.
Oh, okay. I thought it was this August. Thank you. No, okay, perfect. So would you consider that, is that like our good baseline? So for moving forward, we want to move those encounters up to do more encounters, and then hopefully have those encounters really end with some sort of contact that leads to shelter and/or services in terms of treatment.
Absolutely, but I'd like Sergeant Messina just to talk a little bit about what those numbers really mean, because it's coming from his unit with respect to the number that you're seeing for encounters versus the number of placements and treatment and services. So he can better explain the challenges with respect to that. Of course.
Good evening, ma'am. It was great meeting you today. So these numbers, as Kim was talking about, are from when we began the unit, which was back in about August of 2019. So these encounters, daily, we're out there meeting with individuals. This whole thing is a process, though, and we're trying to establish trusting relationships with the individuals on the street. So with many of these encounters, a lot of them are repeat encounters. We want to make sure that we're continuously engaging people and meeting people where they're at. So, for example, there's individuals that have been long-term homeless out there, long-term substance users out there, and we're encountering those individuals daily. Once we establish that trusting relationship, a lot of these individuals ask for treatment. They want to get into recovery, and we're assisting with that process. It may not work the first time, so we continue at it, and we establish this trusting relationship, because eventually it does stick. It could be 5 engagements, it could be 10 engagements with that one individual, but eventually it does work and snowballs in the right direction.
And sir, are you guys measuring the number of times it takes?
You know something?
You say it doesn't stick sometimes and you have to go back. Are you guys also counting that?
We're counting that into outreach encounters, but we're not counting it with individuals.
Are you tracking how many people, when you say doesn't stick, so I'll just use that, if people slip in their recovery, let's say we're successful, we get someone connected to some treatment, they go in, they come back out, and you end up seeing them, they encounter one of the street workers in the team here. How often does that happen in terms of repeat people or who are back out here struggling with disorder, as opposed to being on a longer term road to recovery?
Yeah, it's difficult to really quantify. Like, one thing that we do have is with Section 35s, we are keeping track of the actual individual names and where they're going, if they've been committed, if they've been denied commitment. So we are keeping track of that. For individuals in voluntary placements, a lot of times it does not stick the first time, and they're back out in the street. We're not keeping exact track of how many times that we're getting these individuals into a specific treatment facility. But once those individuals are identified, we are working with them closely and establishing a partnership to be constantly establishing that constant communication with these individuals, which is key.
I have a few more questions. Well, I have lots of questions, but I'm mindful of the time. I want to kind of shift from engagement, talk more about how this work can be more transparent. It was great to see in the slide deck that there's the dashboard on the website. I wonder how we get this information out more broadly. I think residents, certainly neighborhood associations, civic groups, advocates, activists, people are anxious to try to solve this issue. And so we want to bring people in. So one, I'd like to do anything and everything we can to make sure we're being transparent. And then also how we bring folks in. So there's a task force, and I saw that there are some residents there. If there are people who are interested in serving, I wonder what opportunities are available. How do they get their name submitted to be nominated to be on this task force? Could someone speak to how we engage some residents in this work?
Yeah, absolutely, Counselor. That's a great question. With respect to the website, we did publish it, I believe, in May or June of this year. So as we've been doing our walkthroughs like we did with you this morning, and we've done with other neighborhood groups, we've constantly promoted our website, and all announcements we've been pushing through our website as well and getting the word out. But this is, I think, an opportunity for the council to assist us as well in promoting that website and promoting, directing people to the website to show the metrics and show the transparency and all the programs and initiatives that the city is working on. And then I didn't mean to go back, but if you do have additional questions about engagement and outreach, the Office of Recovery Services can also speak to their component of it, because it is the BPD Street Outreach Team, Recovery Services Street Outreach, and then we partner very closely with Pine Street Inn. But again, when we talk about metrics and we start talking about making sure that residences and businesses are aware of all the work that we are doing, we try to drive as much traffic to the website as possible. With respect to the task force, it is 25 members, and we tried to be, the mayor tried to be very cognizant to make sure that it was a representative of all the different neighborhoods that are directly impacted by mass and CAS, be it Roxbury, the South End, and Newmarket Square in particular, and then making sure that we had residents represented, as well as businesses represented, and then also having the institutions in the area. There have been a number of people who have expressed interest in joining the task force. The only concern is that, when we already have 25 people on the task force itself, and when we have so many people, sometimes it is difficult to be able to deep dive into conversations.
I can appreciate
which is why we
that.
broke out into working groups. But always feel free to direct people to either myself or anyone on the coordinated response team in terms of suggestions, ideas, initiatives. Whenever we go out to the neighborhoods, we always talk about, we wish there was just one answer to solve all of these problems. And obviously there isn't, but we're always open to new ideas. I believe it was Councillor O'Malley that mentioned, looking at what other municipalities are doing, and we're doing the same thing, right? We're looking at other cities, doing our research and trying to find creative ways to resolve these issues. So we're always open to having that conversation really from anyone.
So I'm going to just wrap up for this round. I have, there are a number of data requests I do want to get on the record from the South End Roxbury Partnership. And I'll wait for the second round. Mr. Chair, I am very interested in hearing more about these engagements and whether or not we're tracking information like gender, zip code, race, ethnicity, language, etc. I'm wondering if we're having more encounters with women versus men, etc. If anyone can speak to that, that'll be my last question for this round, and then I will save my data requests for the next round so that my colleagues can get in.
I think Jen Tracy or Devin Larkin from Recovery Services can speak a little bit more with respect to engagement and outreach.
Sure. Hi. I'm happy to get those numbers to you. That's quite a list there, and I'm not prepared to give you those tonight, but we can give you the race, ethnicity, gender, and other indicators. Sure.
Zip code. Thank you so much, and thank you again for joining us this morning. Thank you. I will wait for the next round. I know there are several colleagues here who have questions. Thank you, Mr. Chair.
Thank you, Madam President. We have Councillor Flynn, followed by Councillor Mejia, followed by Councillor Sabi George. That's the order moving forward. And I think we may have somebody who has a hard stop, so I might let them present somewhere in between there. But for right now, Councillor Flynn, if you can go ahead.
Thank you, Councilor Arroyo. Thank you to Kim and for your leadership on this important issue, and to Office of Recovery Services with Jen Tracy and her team. I just have one question. I'll be brief. I know others want to ask a question relating to maybe Councilor Janey's question. Kim, if residents want to be engaged, they don't necessarily have to be on the task force, but what is your advice or recommendation on how they can be engaged on this issue, whether you live in the south end of Roxbury or another neighborhood, what's the best advice you could give on what residents or neighborhood organizations can do?
That's a great question, Councillor Flynn. And again, thank you for your work with us on the task force. I think that, the best way to engage with us is honestly just reaching out to the coordinated response team, and as well as, either myself or any one of the city teams. And so I think actually through our website, you can contact us directly as well. And so that's the best way to engage, because then we can guide you in terms of like where you live in whichever neighborhood you're interested in. We can guide you to the efforts that are specific and focused to that area.
Thank you, Kim. I have no further questions. Thank you, everyone, for your important work on this subject.
Thank you, Councillor Flynn, for the paying attention to the time restrictions there. If we can have Leo Beletsky, who is the professor from Northeastern University School of Law, in our second panel. I know he has a 7 o'clock hard stop. I believe he has a prepared statement. If you'd just like to read that or speak that and just be available for questions while he still has time, I'll take him out of order.
Thank you so much, Chairman Arroyo. I really appreciate being here.
Hello? Can you hear me?
One second. Councilor Mejia, Mr. Beletsky, one of our panelists, is going to speak really briefly, and then we'll go to you next.
Oh, you can't hear me?
I can hear you.
Can you see me? I don't even know what's wrong with my phone here. I'm going, so it's not my turn? I thought it was my turn, sorry.
So what, there you go. Thank you. Thank you, Councilor Mejia. Ms. Beletsky, if you could just speak briefly. Thank you.
Absolutely. Thank you so much for having me. And this is an important issue for our city. And as you noted, it is an issue also of national importance. And Boston is a very important laboratory of innovation on these issues. So I think it's especially timely. First, I wanted to just very, very quickly make a note about language. The word substance abuse is not a clinically correct term. The clinically correct term is substance use disorder, and abuse is a term of art in criminal law that signals a criminal act. So if we're trying to move away from criminalization of addiction, I think it's important to use the correct terminology. The main point that I wanted to make is that extraordinary times call for extraordinary measures. And I think that we're not being bold enough in the way in which we're trying to address this problem, which is, a confluence, as was mentioned, a confluence of a lot of different factors. And in many ways, homelessness, substance use, mental health issues are symptomatic of larger disorders in our society. But I think that during COVID-19, all of these issues have really come to a head. And I think that we need to be making more substantial and more innovative interventions in these areas, rather than what I see really is a lot of cosmetic work, a lot of work to important as it is for the residents, but it's essentially a lot of times moving the problem around and dispersing it through the city, which really doesn't address it. There's certainly been very positive efforts that Ms. Tai has described, including things like comfort stations, which I think are really important harm reduction intervention and should be expanded. I think we should also expand that framework to safe consumption facilities, which are a proven harm reduction intervention that has been vetted time and time again. There was a report released very recently by ICER that suggests that these are effective in both the public health and public safety arena, but we are not deploying those interventions. And again, these are extraordinary times. And even though, people might have questions about their legality or other sort of logistical concerns, I think we need to be moving faster and more boldly in addressing these problems. I think that the lived experience of people who are marginally housed and who inhabit Mass and Cass, they may have a different view than the view of the administration. I think that a lot of folks who are advocates and are on the street view themselves as being consistently under pressure and coerced or being removed by force. And I think that's a problematic approach that actually doesn't address the underlying problems and just, again, moves the problem around. I also think that the deployment of interventions has to be rooted in evidence. And I think that I was concerned to hear that the outreach efforts deploy things like temporary detox services and involuntary commitment so frequently, because evidence suggests, the state's own evidence suggests, that the risk of overdose death from Section 35 commitment is about twice or 2.4 times higher than voluntary treatment. I think that the idea that we need to institutionalize people by force is problematic for ethical reasons, but it's also not effective because people end up cycling through the system again and again. And so I think that we need to really rely on the evidence of effectiveness as well as ethical grounds in building the deployment of the menu of intervention that we deploy. I know that didn't get much time, so I'll just conclude there and just say, we need to really deploy much more bold measures, such as including potentially commandeering private property, which in a time of a pandemic is certainly warranted from a public health law perspective. And, people need housing, people need treatment, people need really a lot of support. And what I think, it reflects the experience of a lot of folks is, being moved around by force or by coercion is really not it. Thank you so much for having me.
Thank you so much, Professor Beletsky. Councillor Mejia, followed by Councillor Asabi George, followed by Councillor Flaherty.
Yes, thank you so much again for the presentation. I really do appreciate the updates. I'm just curious, I feel like we talk about the unhoused population is always talked about, but never talked to. And how are we directly activating the communities who are at the center of what's going on in Mass Cass? I'm not sure who will be able to answer that, but I just think it's really important for us to recognize that those who are living the realities need to be engaged in this conversation. And I'm wondering who is doing that and how that looks. I'm also curious about what are we doing to bring a trauma-informed approach to this conversation. Even for the students who are experiencing, who are vicariously impacted by this, just by the mere, just by looking at people who potentially might overdose, looking at the needles that are in the parks. Like, how are we dealing with the residue of the trauma that this is impacting communities? I'm just curious about that work. And then I also want to introduce a little bit of workforce development perspective into this conversation. So far, we've seen a pretty heavily policed response to Mass and Cass. And I think we have an opportunity to, as a city, to train and employ many more social workers and case managers who can do some of the work that's happening in Mass Cass in terms of outreach and leading with a mental health and trauma-informed practice. Right now, I see community activists, just to name a few, the South End Roxbury Community Partnership. They're out there donating socks, they're passing out food. These are people who don't even get paid to do the work, but oftentimes are the ones who are out there doing the work. And I'm just curious about what can the city do to help bring in some of these folks and create employment opportunities for them to do this work and actually get paid for it, because people are getting paid, and it doesn't seem like it's enough. So just curious about what that looks like. So I'll end with that because I know I asked a lot. So I don't know who's going to answer that, but I'll start with Kim. How about you, Kim? You want to take a stab at it?
Sounds good, Counselor. So with respect to community engagement, and I apologize, there's an earlier question about from Counselor Flynn also about community engagement. So the task force is also another vehicle in which people from the community can reach out, because as I mentioned on the task force, there's a number of civic leaders and community groups that are represented through the task force. Also, part of the coordinated response team is the Mayor's Office of Neighborhood Services. So we do have a representation from all of the neighborhoods with respect through the liaisons, Faisal Sharif, who is our South End coordinator, and Jessica Thomas, who is in Roxbury, and I know Faisal was just recently promoted to deputy director, so we do have a new South End coordinator as well. But we work with ONS, and then we also work with our liaisons within the community to engage with the community groups. And I think I had mentioned a little bit earlier in the presentation that we have been doing walkarounds in the different communities all summer. At one point, I think we were doing 2 to 3 walkthroughs with different community groups and civic leaders, and being cognizant of social distancing at the same time to make sure that we were bringing awareness and answering questions and concerns with respect to the MassCast area. With respect to your question about outreach and engagement, I do want to, because you said something about it being heavily on the police department, I would actually counter that. It's actually really heavy on the recovery services outreach and engagement, as well as working with our partners like Pine Street Inn. So I had mentioned earlier that part of the MassCast plan, the mayor had dedicated additional employees and resources in terms of recovery coaches. So we do have outreach and engagement that is more focused on the public health side. And I think when we talked earlier about that balance, it's an incredible balance between making sure that we're doing it with a public health focus and lens to address these issues and these challenges. So I would counter that it is not police heavy. And then with respect to your question about employment opportunities, we always ask those who wish to volunteer to reach out to us to try to coordinate with us, because we do, with our engagements and our interactions, encounter different groups from not only within the city of Boston, but outside of the city of Boston that, either want to hand out food or clothing or try to help in some way or another. So we always ask them to reach out to us so that we can coordinate with them and work with them. And then we also work with Chief Barris's Economic Development Department as well, in terms of making sure that we're engaging with businesses and trying to look at other opportunities for employment. And then I apologize, there was a question that your second question, I believe, had to do with residue, and I apologize, I was wondering if you could clarify that question.
So I do have some follow-up in regards to some of the things that you have just mentioned. I was specifically talking about, there are a lot of community groups that are not deemed civic leaders, or they're not formal leaders, but they are street leaders. They've been doing the work. And I think about a lot of folks who are not at the table. And so I'm really pushing us to really think outside the box in terms of who and how we're defining who is at the table and how they get there. Because I think that some of the folks who I see advocating, I don't see them in formal leadership roles, and I don't see real opportunities for them to be engaged. So I just want to name that. And I'm just encouraging us to think outside the box in terms of like the who we invite to participate. And then the last piece, I see Sheila, you got your hands up, and I know you want to say something, so I'm gonna let you speak, okay? Go ahead.
No, I just want to agree with you, Counselor, and I just want to make people aware that with the homeless, the housing plan on how we're housing our homeless, we do have an advisory, and I think this is what you're getting at in part, made up of folks that were formerly homeless or are currently homeless, and they're called Back Home, and they really guide our work, and we meet on a very regular basis. Similarly, with the youth plan, we have the Youth Action Board, and they are at the table, one, to create the plan, and two, to make sure that we are implementing it in the way that they believe it should be implemented. So we do make sure that in those two initiatives that there are folks with lived experiences, life experiences that are at the table.
And thank you, Sheila. And I'll just add, Counselor, in addition to that, we do have the Drug Users Union and the advisory group that advises on some of our harm reduction work through our AHO program as well. And those are people with lived experience also.
Thank you for that. And the last thing that I want to say is that, accountability is important. You have a lot of folks who, like the Boston Medical Center, there's been a lot of groups outside of the city of Boston that have received funding to deal with this issue. And at some point, we're gonna need to figure out how do we do what's our return on investment and how are these services being rendered, whether or not what we were going to do is really working. And I don't want to overstep my time limit because I see Councilor Arroyo already looking up. I just want to make sure that I yield. I don't think I even have any more time left, but really do appreciate the opportunity to ask my questions. I'm looking forward to hearing.
You can ask it.
Oh, thank you. So yeah, let's get at that then. I'm really curious about the Boston Medical Center and who are we funding to help support this work outside of the city of Boston, and how are we holding these folks accountable to that?
Counselor, when you say who are we fighting, I'm not sure.
Funding.
Funding. Okay,
So,
I apologize.
So I believe I need to know what the dollar amount is in terms of how many dollars were allocated to support this initiative, whether it be through the city, the Boston Medical Center. I know there are a lot of folks who have received funding to address this issue. My question is, who are these folks that have received funding to address this issue, and what has been the return on the investment on that?
When you're talking about funding, can you just be more specific? Because I know you mentioned BMC, and BMC is a partner institution that we work closely with, and we do have representation from BMC on our task force as well. But could you just be more specific exactly what you're talking about, just so that maybe within someone in the panel?
So what I need to know, Kim, my question is, do we know who is being funded to address the issues that are happening on Mass and Cass? If it's only just the city of Boston and that's the only funding source to support this effort, then that's it. That's all we know. But if you know of others, I'd like to know who they are, how much they're getting, and what the return on investment are for the work and the deliverables they're supposed to be producing. That's what I want to know.
Jen, I don't know, because I know that there's a lot of organizations, but Jen might be better to answer.
Sure. I mean, just sort of just answer broadly what I think you're trying to get at is the funding sources that are funding community-based organizations, city services, and others in academic medical centers, et cetera, in the area to address the issues of substance use, homelessness, and mental health. They're varied. You have everything from foundation support to city of Boston dollars that the council and the mayor put forth every year. You also have state dollars, and you also have federal dollars. So there really is there's a wide array of funding streams that come in to provide services.
But what I'd like to know at some point, and maybe not this hearing, because I know my time is up, it's great to know the depth of all the different funding sources. The next question that I have is I would like to know what the return on investments are and how are we holding these different funding sources accountable to the people. So that is, and some might be private and some might be public, but regardless of what their status is, at the end of the day, there needs to be some way to hold these folks accountable to the work that they've been funded to do. And so that is what I am looking forward to learning at some point, and not today, because I don't want to hog up the time before I get gravelled out of here. So I just say thank you. And thank you, Councilor Janey, for convening this hearing order. I know that you've been hearing a lot from folks, and I really do appreciate you hosting this hearing alongside Councilor Arroyo to create space for those who are looking to hear what the city is doing. So I really do appreciate you all bringing everybody together. Thank you. That is all for now.
Thank you, Councilman Mejia. Councilor Sabi George, followed by Councilor Flaherty, followed by Councilor Baker.
Thank you very much, Mr. Chair, and thank you, Kim, for that pretty thorough presentation and everyone who contributed to that. One of the calls that we've received quite a bit over the last few years, and I know that there's been work towards this, as I'm someone who's a member of the task force, as well as my work in the Mass and Cass area, and sort of specifically, and then on these issues more broadly. Can we talk a little bit about the efforts to decentralize some of the services in that Mass and Cass area? And then I also would like to know a little bit about the impacts of changing drugs on the street and how it has impacted and changed some of the behaviors that we're seeing in the area and certainly citywide. I'd also love to hear a little bit about the increase in violence against women, in particular women who are living unsheltered in the Mass and Cass area in particular. And then if we could have just a moment to shine some of the work, whether Len does this or Chief Hooley does this, around the efforts of Squad 80 in particular, because we hear a lot, rightfully so, from Peter Messina and their team around BPD outreach, but I think the EMS Squad 80 has been doing some really important and impactful work in the area. So decentralization of services, changes in the drugs and how that impacts certain behaviors, increase in violence against women, and then the work of Squad 80. Thank you.
Thank you, Counselor. I think Jen would be the best person to answer the first question, first and second question, actually.
Okay. It's hard to keep track of the list of questions that are being asked. So if anyone, taking notes, that's helpful. So decentralization, when we talk about decentralization in the Mass Cass neighborhood, we're really talking about increasing capacity in all neighborhoods so that people can get the care that they need where they live. And that includes neighborhoods within Boston and also neighborhoods outside of Boston and cities and towns outside of Boston. So that is our focus. When it comes to harm reduction services, specifically around decentralization, we're talking about, really work with the state in increasing access to other community-based organizations to provide those services in other neighborhoods. And the way that has looked from Kim's slide is that there's been an addition of other mobile vans providing those services that have the ability to go to other neighborhoods within Boston and be able to get people those services that they need. And also add other organizations other than just the city's programming to that menu of services. Also, a lot of the work with the state is around building capacity to get people into care quicker and increase access to care. I think folks, if you don't know, we operate the PATHS program, which is down on Albany and Mass Ave. That's a program that we, since the mayor has come into office, have doubled and increased the hours and the days of operation. And that program is solely focused on getting people into care. And that's into care in the city of Boston, but also outside the city of Boston. So it's a program that gets people into detox, medication-assisted treatment, and other levels of treatment services, and also provides transportation, which is a service that is not provided by most other community-based organizations. And so the city has invested heavily in transportation, and we transport people every single day outside the city of Boston to get the care that they need. So that's getting people access to care. And then just to finish my thought about working with our state partners around the treatment system inside and outside of Boston is really working on increasing access to treatment, whether that's detox or residential or other levels of care outside of Boston has been a major focus of our conversation over the past year. And we have had some Boston providers, traditional Boston providers, who we work very well with, we respect, and are great partners to us, but also that they have worked on opening programs outside of Boston. So we have Casa Esperanza, who folks may know in the Mass Cass neighborhood, has opened a step-down level of care at the Tewksbury Hospital. So they have now a program outside of Boston. that they're operating as well. It gives us some movement from, people here to there. We also have the Gavin Foundation, who runs a detox and step down service in Quincy now. That's a traditional Boston provider. And other folks that we're working with to just expand really the array of options for people, but with a focus on getting people the services that they need in their neighborhoods. The other question around, I think, was around drug use and sort of with the opioid epidemic, and there's experts on the call as well. With the sort of what we call the fourth wave of the opioid epidemic, if people don't know, the onset of fentanyl to the drug supply, where we, pretty much 100% see only fentanyl now, is different than, 20 years ago, 20, 30 years ago with heroin. And it's a synthetic opioid that works much differently through the body. It creates sort of a faster transmission through the body. And so what that looks like to folks who are observing things on the street is people who are having the need to inject drugs more frequently because the drugs are moving through their body more quickly. It also has created sort of an age difference where different than many years ago, where it would take someone long years of drug use to reach a certain level of addiction and into homelessness and other things. I think we see that happening much quicker with folks, and we see people getting to that point quicker because of some of that stuff. And then I think folks may know that stimulants have been on the scene in Boston for some time now. And that obviously opioids is the depressant. I mean, EMS is on the call. They can talk to this more, more articulate than I can. But with the stimulants, that's a different presentation. That's a different response by our teams on the street, by our medical professionals, by our EMS and our first responders. And so, really training up and building capacity within these systems is part of the coordinated work that we do, as far as how to respond to the onset of the different things that we're seeing and that people are experiencing on the street. So, quiet space aside for people with stimulant use, and really trying to adapt services to meet those folks. But we have, a polysubstance use issue in Boston, where people use different drugs, including crack cocaine, as very prevalent as well. So it requires, I guess, just in summation, a lot of training with our first responders and how to respond in dignified, respectful ways around de-escalation with our folks on the street, because that is what Boston is about, and that's what we believe in. And also within our treatment system and our provider system, sort of adapting to the changes that we see with synthetics and other drug use. So others may want to add into that, but.
And I know I asked a lot of questions, Chair Ricardo, so I'm happy to save the violence against women and Squad 80 for round 2. If you want to move on to other colleagues. Thank you. Thank you, Jen, for that.
And there will be a round 2 for my other council colleagues on here.
Perfect.
With this first panel. Let me just make sure. Councilor Flaherty, followed by Councilor Baker. I see you're unmuted, Councilor Flaherty, but I don't think we can hear you. I know you were having connection problems. Okay, I think we're gonna, I can, all right, I think we're gonna go.
Yes, thank you, Mr. Chairman. Obviously, thanks to the previous speaker. Can you hear?
Yes.
Mr. Chairman, can you hear me?
Yeah,
yes,
you're coming.
So thank you, and thank everyone for the work that they're doing. Just have a question, a couple quick questions. Perfect. What, if anything, are we doing to bring in our suburban counterparts If we do a census down there, and if, I don't know when the last one we've done, I'd like a copy of it. A lot of the folks down there are not residents from the city of Boston. So it's incumbent to help solve this problem, and whether detox and recovery facilities in their area. We're all.
All right, I think we lost Councilor Flaherty. I believe his question was about what. Can you hear me, Councilor Flaherty? You're coming in and out. I'm gonna go ahead and let you find a better.
Now I'm in a better spot now.
There you go. Now you're in a better spot. I can't even mute. So it's.
All right, I'll be very brief. Obviously, it's not just a Boston problem. I want to know what, if anything, we're doing to put pressure on suburban communities and our counterparts to step up to the plate and help solve the problem. If you do a census over there, a lot of the folks over there are not all from Boston. A significant number come from places outside of the city. That's become sort of the mecca and the safe haven for folks. What are the suburban communities to do to provide detox and recoveries in their own community? What are we doing to call them out to create halfway and three-quarter houses and aftercare? That's number one. Two, what's the encampment policy? Because my office is now getting calls from different parts of the city with the cold weather here that we're starting to see some encampments popping up. And we need to address that. And lastly, what can we do to get the bicycle units back? A lot of calls are coming in from different parts of the city, particularly in that area, Mass and Cass, looking for the bicycle unit. They played a huge role, particularly on a lot of the illegal activity and the violence and the drug activity. And so having a presence over there to make sure that if people are over there, they should be there to get treatment and recovery. It also should not be a buffer or a safe buffer zone or a safe zone for them to be engaged in all kinds of activity. People over there to get straight and sober, that's one thing, but that's not what's happening over there. So what are we doing to bring suburban communities to the table? What are we doing about the encampment policy? And what are we doing with respect to the bicycle unit? Thank you.
Sorry, I forgot I was on mute. Thank you, Councilor Flaherty. So with respect to your first question about how we're trying to engage other municipalities, that's where, the city is engaging in conversations with the state, particularly DMH, DPH, in terms of assisting us in having those conversations with other municipalities. And I would invite anyone else on the CRT team to jump in because there are other conversations that happen at that level. I see Jen nodding. So I don't know if you wanted to add something to this point, Jen.
Well, I don't want to put Sheila on the spot, but I think she has been doing a tremendous amount of work with the state partners.
Right. I can't speak to the treatment. I'll defer to my colleagues on that. But as we are preparing for the winter and bringing on additional shelter space, which we do every single winter, we have made it very, very, very clear to the state that we need the surrounding communities to be bringing on additional space for their citizens, for their residents. It's not like we're barring anyone from entering our system, but sometimes people do want to stay closer to home where they have support systems, et cetera. So on November 20th, the state is supposed to give us a good report on all of the additional capacity they're bringing on for the winter. One other thing I will mention is that over the years, and I'm sure you've heard this, there's been a lot of discharge from other systems of care, psychiatric hospitals, House of Corrections, et cetera, into Boston shelters. So now there's the Boston Public Health Commission and Pine Street and others are doing much better data collection at the front door to see where people are coming from. Not gotcha, but oftentimes they'll get calls from hospitals or whatever looking to space. So we're taking that information and feeding it back to the state and saying, you can't have a discharge into shelter policy. You've got to do a better job making sure people get the right supports and the right housing supports before they're before they're brought to shelter. That seems to be working. They've set up resources and ombudsperson and et cetera, et cetera. So I think that conversations around homelessness are more robust than they have been in the past.
And just Council, the last thing that I would mention is both the Senate and House are finalizing their budgets this week. And there's a significant amount of money for substance use disorder, homelessness, public health, mental health. So to you and your colleagues on the council, any advocacy you can do to not only bring more dollars here to Boston, but in encouraging our suburban communities to really step into this fight and so that we can all work together. This is a Commonwealth problem and it's not just a city problem. So as many folks we can get on the team, we would love to have them.
So with respect to the second question, Councillor Flaherty, is with respect to the encampment policy. So we do have an encampment protocol that is focused on the public health lens. And I had briefly mentioned it in the presentation. So the process right now is that either someone within our coordinated response team sees an encampment and engages and then coordinates with the rest of the coordinated response team. But typically what we do is we receive a 311 complaint under the unsheltered persons category that comes directly to the coordinated response team. So the first point of contact is then from the ISD investigations and enforcement team, and they go out to assess the situation, verify the location, as well as how many individuals are there. And then at that point, they post a notice stating that there will be a cleanup of the site. However, at that point, we also engage through our recovery services outreach, Pine Street Inn outreach, and our other outreach teams consecutively to make sure that we are offering treatment, offering services, making sure that the individuals are aware of all possible resources, and that just to explain that, you know, the space, a public space is not safe for both them or residents or businesses. And so on the third day, we do return with DPW, mobile sharps, and our recovery coaches and outreach teams for a final cleanup, and then assist anyone that needs any transportation to treatment or to services. So in terms of constituents that are sending any complaints to the council, I would recommend if they could please submit a complaint to 311 and then it comes to us directly. And then that way we can address any encampment and make sure that we're providing quality of care. And then in terms of your third question with respect to the bike units, I'm going to hand that over to Sergeant Messina to address.
Good evening. Yes, so there is a citywide bike unit specifically assigned to days down in the Mass and Cass area. I was a previous member of that unit myself prior to coming to this new assignment. they're not under my responsibility, however, right now. So I can't speak regarding to their daily deployment, but there is a bike unit assigned to the Mass and Cass area.
Thank you all for your time and attention to this, and look forward to continued partnership.
Thank you, Councillor Flaherty, and best wishes on that situation. Councillor Baker.
Thank you, Mr. Chair. First, I'd like to say, Kim, I don't know if I came off in my original statement saying that I don't think anything is happening. I don't mean it like that. What I meant to say is the amount of time and energy and money and eyes that we have on this area. It just seemed that during COVID, we were just kind of swamped with what was going with all the issues that come with this. Kim, can you talked a little bit about the command center in the Miranda Kramer. Is that getting closer? And the Miranda Kramer building is the building that's on Mass Ave under the catwalk across from BMC. Where in the building and how far along is it?
Sure, Councillor Baker. And I do appreciate that clarification, and no, it did not take that away at all, but thank you. I do appreciate the recognition of the efforts that we're doing in the Mass Cass area. So with respect to the Operations Command Center, I had mentioned earlier that the BPD Street Outreach Unit will be moving to 725 Mass Ave through BPHC. So that is a BPHC space. And the idea, and that's really the first step towards an Operations Command Center. The idea being, when we visited San Francisco, they had, put together essentially a command center of their public safety teams, including their coordinated team, to make sure that they were responding timely to encampments or any situations or incidences relating to unsheltered persons. And so this was really an opportunity to also get the BPD street outreach team into the epicenter of the Mass and Cass area, because they were formerly at police headquarters. So it gets them a little bit closer, but that's also the same building where Chief Hooley's EMS services is, and BPHC services. So it's really an opportunity just to make sure that we're all located in one physical location. And it also adds an additional police presence to the area that we think will be helpful to the quality of life issues. And then, we'll be working towards making it, expanding the command center itself.
Excellent. And I that's good news. I just think that the future of policing, the way we're going about this, there's been a lot of talk about how we need to change the way we police. And one of the ways that I would change the way that we police, I would take Deputy Stratton's unit and Peter Messina's unit, and I would build them up. I would add to them. I would make them a group that was more sought after, like the gang unit or the drug unit. We need to pair with people that want to go out and help people with the best clinicians. I think it's something that we should. I know I'll be advocating in next year's budget to add to this group. Sheila, on one of the slides, it said there was 558 long-term units, but then there was another number, 729. Is that just temporary? Like, what is the difference there?
So the 700 and the 500 number, what that chart was about, Counselor, was it's even though we've been able to house 2,400 homeless individuals since 2014, it's become really clear that a lot of the Boston residents need 24-hour, 7-day a week care, support services.
Yeah.
So we've been making a concentrated effort to build more permanent supportive housing. So that demonstrates the pipeline. It doesn't demonstrate everything we've done, but there is a renewed effort here to build permanent supportive housing. The good news is we do have 500 units in the pipeline. The 700 there's 700 in those developments. There's 700 total units. 500 are dedicated to the homeless.
Oh, okay. So they're all apartments. They're all long-term housing. It's not like there's 120 units that are rooms that may just be for people that are higher need and maybe moving to someplace else. They're all.
These will be dedicated for homeless individuals, and there's one family development on there, but homeless individuals with 24-hour, 7-day a week services.
Yeah. Jen, maybe this question is for you. I heard a comment earlier about like number of beds in that entrance, the detox beds. Where are we as far as utilization of those beds, the detox beds, and then the step down beds? Are people actually, because there were so many people on the street, are they not trying to access that initial treatment and then the step down? Can you give us a sense of what's going on there?
Sure, I can. So COVID really affected the system, as well as, there was a lot of fear, I think, from people around going into programs because of COVID. So I think there's a multitude of factors, this summer, including, the weather. The weather was good. We had a great summer. But I think, treatment programs like the shelters had to develop their own protocols and reduce some capacity. So we did see some admissions to treatment programs slow down quite a bit in the beginning of COVID. We have seen that pick up now, and we are seeing, just in our PATHS program alone, more people walking in, more people going into treatment. So that has increased gradually over, really since June and more so this fall. So we are seeing more people go into treatment, and then with the weather getting colder, that influences that somewhat. We're seeing more people into the engagement center as well, who are, gives us the opportunity to sort of engage and have conversations with people and, really try to meet their basic needs and start that work. So, I think the easiest answer I can give is that COVID did create some access issues in the beginning, but I think we're back up. We were able to get people into treatment. There is availability, if that was the question.
Yeah, that's part of the question. And access. So were they having difficulty accessing the treatment early on in COVID, or you think people were just generally scared to go into it?
Both, because programs had to sort of close for a bit.
Yeah.
They had to take rooms that were online, and they had to take them offline for quarantine or isolation. They had to figure out spacing issues, just like we did. We had to create a lot more outdoor space because of our small spaces inside. And so the whole system went through, sort of responding to COVID.
Yeah. Thank you, Jen. So we are seeing those numbers creep up. We are seeing people starting to go after the treatment and the beds more now.
We are seeing more people going into treatment, yes. But I will say COVID is still here. And so the capacity within the programs is still altered.
So are we having a capacity problem? Your opinion?
We have not faced a capacity problem at paths yet.
Yeah.
So, we'll see how it goes. We watch it every day.
And just because you mentioned paths, I want to mention something. I was at a meeting a year or two ago, and it was for a Massachusetts meeting on recovery. And one thing that I heard over and over, and particularly from people down the Cape, was we come here because we want to use the PATHS program. So how do we get a PATHS program down in Falmouth and down in other places? So I just want to give you guys a shout out. I know the work that you're doing over there. Kim, we've talked a lot about the issues that are going on in the South End with defecation and that sort of stuff. What do the numbers look like there? We had talked about mobile bathrooms and that thing, and we had to engage a company that would clean up human matter on public private spaces. Are we seeing a decrease in that? Are we still talking about bathrooms? Like, how active is that group that has to go out and clean up the fecal matter?
That's a great question, Counselor. So the BPHC had hired a third-party vendor to pick up human waste on private property. And I think that, one thing that we realized through the pandemic was the lack of access to bathrooms that was causing, or was one of the factors and one of the reasons why we're seeing an increase in complaints. And that's why we rolled out the pilot program. As of last week, we only received 24 complaints, all of which were closed and resolved within 24 hours. I'd have to go back and check what this week's numbers were.
Yeah.
So it's not an untenable number, but it's still a situation, right? And I would say that this is a discussion that's happening in the task force at the working group level, because when we start talking about public bathrooms, and this is something that is not unique to Boston, it is an issue in other cities like Philadelphia, San Francisco, Portland, LA, and in Denver, is the issue when we talk about public bathrooms, there's the concern for illicit activities or dangerous activities, as well as placement and location. And so those are really challenging topics, yet at the same time, still wanting to provide access to bathrooms. So I know that there's conversations that we are having, with providers and services in the area, if maybe they can provide access to bathrooms, even though they're not open during COVID right now. We are looking at, talking to faith-based communities as well in terms of access to bathrooms. So I think the conversation is still ongoing. The pilot program, we're gonna take a look back at the end of the year, look at the numbers and see if it makes sense to continue it, whether or not we want to expand it any further. And then also look at, are we talking about adding mobile bathrooms or are we talking about permanent bathrooms? Because, Boston has had permanent bathrooms before that have been fairly unsuccessful. And
Yeah.
we don't know if that's really because of the location or because of usage, right?
Yeah.
So that is some research that we're doing right now, but we're trying to move quickly towards coming to a resolution with respect to that.
Well, any bathroom that we land will have to be manned. There's no way we could put a bathroom someplace and not have it manned. Thank you, Kim. Peter Messina, can you talk a little bit about what a typical Section 35 may look like? So going through the court, and then after the court proceeding happens, what do your officers do? Do you drive people to drive people to where they're supposed to go? Can you just give us a little bit of an overview on that?
Yes, sir. Good evening. So one thing that's important to stress, especially for the street outreach unit, is that we use Section 35s as an absolute last resort. This past year to date, we have 45 applications Section 35s through the West Roxbury Court pilot program, which, by the way, just to plug it real quick, it's a phenomenal program. It's an awesome tool for our tool belt. Judge Coffey has been just amazing throughout this entire process. So Section 35, like I said, is used as a last resort. First resort is making sure that we offer voluntary solutions first. We want to meet people where they're at, offering voluntary services. If the person reaches the point where they do not have the ability to care for themselves anymore and they're in great danger to themselves, then we petition for a Section 35 through West Roxbury Court through the pilot program. Once that petition is issued, it's a pretty quick process, but we make sure that our affidavit during this process is very thorough. So we compile all of the incident reports involving this individual, all of our interactions with this individual. In addition to that, we make sure we have field interrogation observations compiled against this individual, and we present that to the court. We want to make sure that the court understands what we have done leading up to this Section 35 petition. So once we present this to the court, a Section 35 warrant of apprehension civil commitment is issued. That civil commitment allows us the opportunity now to engage this individual and pick them up on that warrant. Once an individual is picked up, he's transported directly to West Roxbury Court, where he is seen by a court clinician. He's appointed an attorney and then represented in front of a judge at West Roxbury Court. If that individual is committed, if the judge finds that there's enough clear and convincing evidence to actually commit this individual, that individual is transported to a treatment facility usually in Eastern Massachusetts. So out of the 45, just to highlight, out of the 45 that we have petitioned this year, only one has been denied by the courts. So this is an excellent track record. And so I just want to stress the importance that it's used as a last resort in my unit.
So if you start a Section 35 first thing in the morning, 9 o'clock, how long could it take you to get one done?
It takes all day. It's a time-consuming process, and that's utilizing the pilot program.
So will that take you and another officer out all day long, or just you?
It takes one officer the majority of the day to compile everything, but then when we find the individual, it usually takes two of us to bring the individual to West Roxbury Court. It is a time-consuming process, but the pilot program under Judge Coffey has really been fantastic in process forward.
Yeah. Okay, Mr. Chair, I'm almost done. One more thing. Jim Green, can you talk a little bit about, because one of my frustrations that I have, it seems like maybe some of the community people and some of the advocacy people are disconnected. You have a lot of advocacy type people looking to don't move the encampments along and that sort of thing. What's the quality of life for someone that's living on the street? I mean, are we doing them a favor by allowing them to stay on the street? Dale, can you talk about that a little bit?
Councilor Baker, thank you for the question. I would just say this, having spent, the better part of the last 35 years engaging people on the street, I can't imagine anyone on this call, anyone who, I feel like all of us at the city are advocates on behalf of the people on the street. Feels like the quality of life that we see playing out on our sidewalks or, in our parks is dignified or or healthy or helpful in the long run for people. I mean, people really are sick and suffering, I think, as the mayor often says. And, you know, Councilor Mejia asked the question before about trauma-informed work. I think a lot of the direct encounters people have about offering people, you know, clean socks or water, the things we do at the engagement center. I'm very proud that in the city of Austin, quality of life, when we talk about it, is not a circle that all of us have, but homeless people are outside of it, but that the quality of life of people, I think the reason that we've gone from 4 outreach workers to 8 to 16 at the Recovery Services Division and Pine Street is to engage people and try to help people connect and think about trying again to break the cycle and move from where they are to where they aspire to be. And I think there's a lot of intensive work to motivate people. I think it's worth it to try again. A lot of people have tried and failed, et cetera. But, you know, I don't think anybody can miss the fact that people are sick and suffering. The number of calls that Squad 80 responds to for people that have overdosed or are struggling medically, the people who cycle through emergency rooms and healthcare for the homeless. So I think that, you know, in general, I think what I hope is one point of agreement for all of us is that we want to offer people pathways to transition from the streets into a place where there is care and healing and recovery available for them. And I think that, you know, it's a real challenge. And some people from the streets, you know, they do better. They connect through a medical pathway to a recovery and healing process. But many of the people that we see, they do spend time in the shelters. They do access a range of services. It's how we work together to break the cycle. And I think that's why the relationship building and trust building that you see at the PASS program, that you see among the street outreach providers, the peer recovery programs, even, you know, Project Place that does work, has a lot of people who have been homeless, have been previously incarcerated. They're a real power of example to people that, hey, I was there and I know what that's like. And I'm here now. All of that encouragement to offer people support to break the cycle. Because no, life on the streets, I mean, it's, you know, it's incredibly challenging for people. And I think the long-term prospect for people, we see it, the weathering of people's lives, the health issues that they face. So, you know, I do hope that one thing everybody on this call is pulling in the same direction for are supporting the pathways and the healing and helping relationships that break the cycle for people and help them get off the street into a better place.
Yeah, well, I mean, even Jim, going back to when Long Island, when the bridge was closed, the trauma we all went through when relocating all those people basically to around the south end. But then what came of that, where we used to just let people go to Long Island, then they would get in vans and be dropped off in various neighborhoods that the next day. Now, the homeless people, they're being triaged down at 112. We actually know who people are. We're looking at them. We're finding out who they are. We're finding out if they have a dual diagnosis or what it is they have. So just what we've done in the past 7 years is totally different thinking from what has been happening. And I am concerned that, you know, if I don't want to become the cities that you see like LA and San Fran and follow some of their pathways. I think we need to have a mix of that compassion, but also things like Section 35s and things like the encampment protocol, because I don't think we're doing people a favor by not, you know, I'm trying to say is I think we need to be somewhat strong in the way we deal with this, strong with compassion, like a mother or a father. I love you, but this isn't a good decision for you. So thank you, Mr. Chair. I hope I didn't go on too long.
Thank you, Councilor Baker. And I'm going to take this moment to answer questions, ask questions myself. There will be a second round. So if you're a councilor and you would like a second round, now is a good time to raise your blue hand so that I go down that list. Also, if you are an attendee, and we have many of you, and you would like to give public comment, please raise your blue hand. That'll help us speed that process up when it comes to your time to speak. So if you can start raising your blue hand so that we can get I see it's just going right up. So thank you so much for that. It makes it quicker for us to identify you in the pool and give you your space to talk. Thank you. And thank you for your patience today. So I'm going to try and direct these questions to who I believe is best suited to answer them. But if anybody feels that they are also suited to answer it, or feel perhaps like I'm directing it to the wrong person, please feel free to step in, raise a blue hand, or unmute and just answer. There's so many Zoom boxes that I won't necessarily see you if you just raise your hand. So feel free to unmute and just jump right in. So I see here that we had the public safety update. It looks like we have done 1,494 outreach encounters since August of 2019. Is that accurate? Kim?
Yes, that is.
Okay,
That's coming from the the BPD street outreach unit only.
Perfect. So let me just direct this to it's Sergeant Messina.
Yes, it is, sir.
Thank
Good
you.
evening.
Thank you. Good evening. Thank you for being here. So on just so I can make sense of these numbers are, so for instance, that's 131 Section 12 placements, 64 Section 35 placements, 124 voluntary substance use placements. Is that per individual, or is that possibly somebody multiple times?
So we'll start with, I'm looking at numbers right now for year to date. You have numbers from our inception, which was, I think, October or August of last year. So I can speak directly right now for the Section 35 placements year to date. Those are individuals. They're not repeat.
Okay, so I think you said, was the number in answering Councilor Baker, you said you had 45 that went to the
this year were 45 for year to date.
So that's from January to today.
Yep.
There were 45. So that gives whatever that discrepancy is from 45 to 64 between August and January.
2019 to January 1. Yes, correct.
Okay. And then the permanent housing placements, is that the work of BPD there in terms of, because I see there's 9 permanent housing placements, which is why I wasn't. So go ahead.
These 9 are a direct reflection of the Boston Police Department Street Outreach Unit. However, we have a partnership with Pine Street. We work with Pine Street daily, and we conduct outreach events, if you want to call them, weekly. Just actually today with Council President Janey, we walked by Pine Street, our partners, as they were out there at Washington Street and Melnia Cass, providing a housing voucher to someone. So I don't have the exact number, but I do know that it's significant. I know we have 12 slated through Pine Street from now till the end of the year to get housing. These are individuals that are homeless, that were living down in Clifford Park or down in the Washington Street, Melnia area. We also have a plan right now for next week and the week after. We're going to start attending and going out with Pine Street on the overnight to meet people where they're at. Because once we do that, we will be able to get those individuals identified and into housing, hopefully by the end of the year. So that number 12 may rise significantly in the coming weeks.
And that's 12 on top of the 9. So that's 12 currently going through the pipeline?
Yes.
Thank you. And so I have a couple more questions for you, but I'll do them in the order that I have them written down on paper. So they're going to be a little bit everywhere. In terms of just to stay on housing, as a public defender prior to this, I can tell you that the key word that I always look for with my clients in terms of what I was trying to do was stabilization. Most of these folks aren't stabilized, and so they're thinking about where their next meal is going to be, where they're going to be the next day. If they have a substance use disorder, they may be thinking about how to combat that or how to get treatment on that, or frankly, how to satiate that. And so there's a number of different things that are happening in their life that are unstable. And I think the key thing here that I've always truly believed is housing should come first. I really do believe that when we start to put people in permanent housing or shelter, we can really hone in on all of the other things in the treatment sector that we need for them, whether it be mental health or substance use treatment. And so for Sheila Dillon, first off, thank you for the work that you've put in on a number of different issues. I know during the early outbreak of COVID, you were really working on ensuring that these communities were receiving the care they needed. And so my question is a few questions based on that. In terms of permanent housing, what programs do we have available beyond the Tyne Street Inn to get folks into permanent housing? And how restricted are we in getting folks housing before they're in recovery? In other words, is there housing opportunities where the recovery doesn't have to come first? We can take that person off the street, off of, living, day to day, and put them into housing first. How many programs are restricted in the way that don't allow us to take them off before they're in recovery? And how many do we have that are recovery focused first? You have to be essentially in recovery to receive the housing.
No, it's a fabulous question. And so every single week, in addition to the street work that's going on with Pine Street and Jim Green and the Boston Police, there are groups that come together every single week, even COVID, and they're looking at all the folks in shelter, folks that are on the street, and saying, what housing resources do we have and what do they need? And some of the folks can access just regular housing with additional income. A lot of folks, though, that you're pointing out, really need very low barrier, low threshold housing, of which it exists. I would argue, and I think you would argue, there's not enough of it. It's a state funded, very intensive funded housing resource that I think we do need more of, and we're lobbying the state for more of them all the time. But that is like, take person off the street that has a drug addiction and say, here you go, here's a key, go in there, get well, and we're going to provide you services. So there really is a wide range of housing that's meeting a wide range of need. But I do think, and we're talking about some more permanent supportive housing and low threshold housing, we really do need to beef that up. We need to grow that stock. But it does exist, and it does exist in Boston.
But obviously, and I think we're both in agreement on this, not at the numbers we need them to exist at.
Right, for people that really are coming right off the street with addiction, we need more low threshold housing, yes.
And so one of the questions I have on this is, I know that we had to, the peak in terms of COVID for our unhoused population came very early, it came before April. And I know that you did a lot of work with others on this call as well in trying to figure out how we address housing folks and getting them the treatment they needed for COVID during the pandemic on short notice with a number of different barriers that we had issues to. And I guess my question is, if we were able to set that up for folks who needed that during COVID for that specific purpose of them getting well in terms of quarantining and doing the things we had to do, what access do we have using those same resources or those same things we learned to try to house folks now?
So you're right. During the first wave of COVID and now the second wave of COVID that we're looking at, we're setting up a lot of temporary shelter spaces that didn't exist, and using an unusual array of resources. And I think we can learn from how quickly everyone moved, acted, funded, coordinated, as we look at new problems. And so I think we can learn from that. The difference is temporary versus permanent, right? So with permanent housing, we've got to find the locations, we've got to find the funding, we've got to find the providers, et cetera. And we do have a lot of, affordable housing in the city. We have a good amount of permanent supportive housing, but it is a more complex, it's more expensive. It takes a wee bit more time. I think though, we are very, very committed to bringing on a lot more permanent supportive housing than we've had. And we need to get the state to get stuff out of round, stop making it competitive, and just make the funding flow. And we've already identified 500 units. We'd like to identify even more than that. So I think we all need to just, push the state, push the feds, and get the resources and get it done, a lot of which is underway.
I appreciate that. In any way that I can in my office can be roped in to help on that, please
Great.
do let me know. Because, what I will say is study after study has shown that the cost of not doing anything is incredibly expensive. This isn't free, right? When we're not providing housing, we're providing emergency services, we're providing recovery services, we're providing treatment services. If you're going to section them, you're taking a whole day of a judge's time, you're taking a court clinician's time, you're taking the court's time. All of this adds up. And so if we're going to talk about, restrictive costs, or we're going to make arguments about where we're going to put our money, I think, it's really important that as we send these messages out, that we make it clear you're paying for this one way or the other if you're the state. It's not, saving you any money. In fact, you're probably paying more money to keep folks unhoused and out of recovery than you would be if you stabilize these lives. And so for me, this is just me personally saying, anything I can do to push on that with you, let me know.
Great.
Because, these, for me, I think housing comes first, and then we can start to do the other things. So let me just go back. I believe, Sergeant Messina, I'm going to ask you a bunch of questions at once so that we could just kind of get you situated. The first one I have is, what role does the state police play in the area of mass Cass? If any? They're obviously not here today, so I can ask them. But if you know what role they play in this area, do they work with the intervention team at the city level, or do they kind of operate individually on their own? Is there any oversight to whatever they're doing as far as how it impacts you? You're muted.
I wish I could speak about the state police deployment in the area. I'm sorry, I can't. There is a supervisor that we do make contact with occasionally for the area, but I can't speak on their in particular about their deployment down in the Mass.
So do we know if they do any work with your intervention team?
We do have a relationship with them. So they do work with us occasionally when it's needed, but like I said, I can't speak about their deployment in the area.
Okay. One other question. It's not the last question, but one other question, not about the state police. It looks like in the update, there was a mention of sort of a quota, the 10 referral quota. So in the Melnia Cass Plan 2.0, a couple of the highlights that came out of that was a quota of 10 referrals to treatment per week. Is there a quota for that?
No, we don't work on quotas.
Okay. And so I guess the other question sort of based on that is, you've said that Section 35s are a last resort for the intervention team. What circumstances do you need to see personally in terms of what makes it a last resort for you? Is it a matter of them not accepting voluntary services, and then that's the next step? What are the steps that you're checking a box on or checking a list on before you say, okay, Section 35 is the step we take now?
So we are literally looking at situations where this individual cannot take care of themselves, meaning they're falling into traffic. They're being either struck by motor vehicles or almost struck by motor vehicles. They're lying on the ground in 10-degree weather, where it's only a matter of time where something significant is going to happen. So it's a totality of the circumstances of each individual. So it's not about if an individual keeps on declining services after a period of time, then we say, okay, enough, we're not going to offer you services anymore. We're just going to section you. We see these individuals rapidly deteriorating to the point where they may die sooner rather than later. And that concerns us, and it weighs on our conscience.
So just to clarify that, it sounds like depending on the situation that you're seeing with your own eyes, it could be the first contact you have with this person is the Section 35 them. If they're, say, swaying in and out of traffic, as you said, or something like that. If that's the first time you see them, you might Section 35 them right there on the basis of that.
No, that is not. I believe that's a misuse of the program, and we would not do that, especially in the street outreach unit. We establish relationships with the individuals down in the Mass Cass area. My team is phenomenal. So we know.
So you would have to see that multiple times. Is that what you're saying before you would Section 35?
We would look at the totality of the circumstances, and we will want to see multiple different situations where we would have to get that, where it would cause us to, I guess, tip the scale to make it so we have no other options at this point but to utilize Section 35. But just to kind of harp on it, we do, when we are dealing with individuals out there, I mean, part of the thing with the street outreach unit is that our partnerships are key. Having partnerships in anything in life is key. So we want to make sure that when we're dealing with an individual, John Doe in the street, that we're running and we're working with our partners to identify the root cause of what's going on with this individual, because our partners may already have a treatment plan regarding this individual. So we don't want to derail that treatment by going forward with the Section 35. So we want to make sure we're working with our partners in all that we do. And part of that we talked about initially with Kim discussed was the hub model. We want to make sure that we're implementing this hub model down there so we can continuously work with our partners so we can all come to the table to collaborate to move this forward.
And are you seeing Section 35s when you've had to move forward with them? Have you seen that deteriorate the trust that you are creating with other folks, if in terms of these relationships and trust-based relationships you're trying to create with folks there, if they see you as somebody who might involuntarily section them at some point, does that hinder your ability to create a trusting relationship with them?
No, because
Have you experienced that?
So meaning like trusting relationship with our partners or trusting relationships with our
No,
clients?
not with the partners, with the community there, with the substance use community there, with the homeless there. The fact that some of times they can see a community member, one of their peers or somebody that they know, taken away involuntarily. Have you seen that impact your ability to create trusting relationships with them?
No, it's actually the other way around. The clients out there understand on how much we care for them, and they're actually coming to us. So prime example is myself. I was out there. Someone came to me and said, "There's an individual out here, it's female, who has a severe abscess in her leg, and she's going to die. You need to help her. She needs to be sectioned. You need to help her." I have countless success stories of Section 35s that we have done that have proven to be not only effective, but life-changing. So it's established more of a trusting relationship with the clients on the street because they know that the system is not being abused, and they know that we're using it because we genuinely care for the individuals out there.
So I appreciate that that you do. In terms of the, let me just see here. I just want to make sure if I have any other questions for you that I ask them now. One last question. When you're determining the size of the police presence in Mass-Cass, how are you making that designation? Is it based on the amount of folks there? Is it based on the amount of calls you're getting? What are you using to calculate who and how many folks are there?
So I can speak for like my unit, but I cannot speak for any kind of deployment for the Boston Police Department as a whole in the area. So I don't make that determination regarding the police response and our strategy or anything like that.
Yeah. Thank you.
You're welcome.
I think, Kim, this will go to you and then you can direct it to somebody else if it's more appropriate. How often has the task force met since its creation?
So I don't have the exact number. The task force started meeting in, I believe, October or November of last year on a monthly basis for 2 hours. And then in the last few months with the working groups, we've been meeting almost weekly.
So in between November to now, you've kept monthly meetings?
So we have a monthly meeting every single month. And then in addition to that, since we started the working groups, I want to say about 2 to 3 months ago, we've been meeting once every week or every 2 weeks with the working groups.
And in terms of the meeting minutes, are those available publicly? Are they on a website?
They can. They're not published on the website as of yet, but we're definitely trying to put everything together to publish.
And then another question that you might be the best person to answer, maybe somebody else, and you can direct it that way. You mentioned that the task force is breaking into sort of smaller groups to specialize in certain issues, which I makes sense. It's a big group and you want to focus them. But in doing that, the task force was created the way it was so that we would have a diversity of opinions on multiple issues, a diversity of perspectives. What's being done to ensure that those groups aren't being siloed in a way that is eliminating sort of that diversity of opinion, that different perspectives and lenses?
Of course. So the working groups meetings invitations are sent out to every single task member, whether or not they want to be part of the working group or not. And then we dedicate a portion of our task force meeting to review the working group recommendations and discussions and deep dive and give a summary, and then give the opportunity to the rest of the task force to either indicate if they would like to expand that conversation to the entire task force and deep dive as a whole, or if they want it within the working group to continue that conversation.
Thank you. That's helpful. Is Devin Larkin from Recovery Services still on the Zoom?
Evan actually had a family issue, so she's not, but I'm here.
Okay. So you may know this answer. In terms of the data behind Section 35s and leading to overdoses, and I'm just full disclosure, as a public defender, I've been in court on the other side of Section 35s as a defense attorney. I can tell you, in my experience, we suffered, I personally have had 3 clients overdose after a Section 35. And the purpose and the reason for that I found was that when they're involuntarily detoxed, they have built up an endurance to whatever substance they're using, whether it's heroin or fentanyl. And then when they're involuntarily detoxed and they're let go, they use at the same rate they were using at before, and it leads to an overdose and death. And so as somebody who's experienced that on the opposite end of it, my question is, are you aware at the Boston Public Health Commission of the data around Section 35s and the harm that they may cause?
I am aware of the data that came out of Chapter 55 report by the State Department of Public Health that indicated people leaving incarceration and including Section 35s as well have a higher rate of overdose.
And so I guess my question for this, because I do not have the power to do anything with Section 35s, is what are we doing on the provider end to ensure that if we are having folks sectioned, and it sounds like we are at a 44-to-1 clip, what are we doing to ensure that the resources on the back end are made especially available to them, because we recognize that data says they are at that moment more at risk than they were before they walked in. They're 2 times more likely. So what are we doing to sort of stabilize the fact that now they've gone through this process, so now they're a priority for these resources? Are we doing anything to track that? And you might not be the right person for this answer, but what are we doing to ensure that none of those folks slip through the cracks, so to speak?
I think that's a really good question. I'm really not the right person to answer it, but I would say that that's very intentional work that we need to do as far as following people through the system. But I don't have any answer on that other than what I would say for down in Mass Cass is with the coordination with Sergeant Messina's team and all of the providers in the area. We do try to wrap a very tight wraparound services around these specific individuals in the neighborhood, and it takes really all of us to support those folks who end up coming back to Mass Cass.
Thank you,
Councilor Arroyo.
Counselor, sorry, go ahead, Barry.
If I could, so first of all, I really appreciate you raising that question. And I know I've gotten to know Sergeant Messina and the group, and I know how much they struggle with it. We as a program at Healthcare for the Homeless also struggle with the concept of Section 35. One of the things that we've done, and this is just around the incarceration piece, is we now have a team that's in the Suffolk House of Corrections, because as you know, it's not just Section 35, but if someone's been using substances, and as Jen pointed out, it's almost always polysubstance use, their body then becomes naive during the incarceration. And so we have teams in the jail that are meeting with folks and starting them on medication-assisted therapy, starting counseling in the jail. And then we actually have a team that meets people upon the day of release and tries to bring them back to our main building. So I agree. I think it's a very significant issue for all of us. Thank you for raising that.
Thank you. And Mr. Bach, I know that you have a hard stop. So after my next couple questions, I'm going to go to you to present before I do that second round.
Thanks.
So thank you for your patience.
Counselor Arroyo, just to continue your last question with respect to the Section 35, I do want to contextualize the numbers that we're talking about, because with respect to what public health is reporting, in October of this year, there were 265 treatment placements, And then year to date, since January 1, there's been 3,392 treatment placements. So that's just to contextualize the numbers that we're talking about in terms of treatment placements in comparison to the BPD street outreach, which is Sergeant Messina and the 5 officers in his unit with Deputy Stratton.
Thank you so much. Mr. Green, I think you're the next best person for this question. In terms of encampments, we've heard a lot about clearing encampments. What are the perceived benefits to that? I think, the reality is, for me, when I see an encampment cleared and then it comes back, and then I see it cleared and then it comes back, other than serving to further destabilize, is there any positive that comes into this in terms of like what happens when you clear an encampment? Do we set them up for housing, or is it just a move on? How does that work? And if you're not the best person to answer that, I'm happy to have somebody else step in.
Councilor, what I would say is where my focus is when we are aware, and usually we're aware of and engaged with the people who are staying in encampments before whatever protocol gets tripped that might involve clearing an encampment, which is usually, I think, my understanding is it's driven by complaints around safety, around criminal activity, around violence, around issues impacting the life of residents. But what I can say is we get 311 calls, we get direct calls from your office and many counselors' offices. We send outreach out to assess and assist people and do the relational work and motivational work. And very often, I think we saw a lot this summer of Ramsey Park over to the corner of Mass and Melnia near the school bus yard, and then back around to the sidewalk. A lot of that is people packing up, tents or their tarps and other things, and then moving and then setting them up again overnight. But in all of those cases, the role of outreach workers is the relationship building and engagement and the trust building to continue to work with folks around their motivation. And I would say in many of those instances, if you go and talk to people staying in the encampments, they can tell you, I'm working with this counselor, I'm working with Mike O'Neill from Pine Street on a housing application. This happened over by the public works yard under the highway, literally across from Pine Street Inn. There were a lot of people down by the West 4th Street Canal where there was a little epidemiological outbreak of some gastrointestinal problems. In all of those cases, outreach workers are going in there several times a day throughout the week and sometimes at night. And there are multiple entities that do this kind of outreach, but that are going in to work with people around, what is your situation? Have you done any housing applications? I think last year, directly from the street into housing, 100 people were placed through the program that we fund at D&D from Pine Street Inn's housing into permanent supportive housing, and many other people into long-term medical care. But there's a lot of work you don't see of case management between different agencies around vulnerable people, and also around, they've actually utilized, I think, the police street outreach unit to get some warrants cleared for people, because as you know, that can be a real barrier to housing. So the role in outreach is really trying to engage with people around what they actually aspire to. And I would say that we've seen sometimes the resilience that people show when they're putting up a tent, it serves them very well when they transition into housing. But the relational work and the referral work and the applications, the programs that Sheila was talking about for our supportive housing, it's been wonderful for me to see, doing this work as long as I have in the city, that our street outreach clients are fully integrated into the prioritization around housing access for the city's supportive housing programs. So we have a lot of folks. So what's important to me is that the outreach workers, whether it's the Pine Street team that D&D funds, the AHOPE program and others, that the relationships they have with the clients are ongoing, and it's not like they end if there has to be a mitigation of a site or a location because some issues of safety or violence. So, the people coming and going with motorcycles, and that are involved in kind of drug exchange and are in and out are not the clientele, but the people staying in those locations are the ones the outreach teams are building a rapport with. They usually have a by name list, which is what Sheila asks of us, of people they're trying to work with. on housing and on other long-term placement needs. So I would
Thank
say
you.
what.
I don't want to have to cut you off, but we do have, we got a
Okay.
lot going. And so that's going to be my last question of this round. Mr. Bach, I'd like you to present because I know you have a hard stop. And then all my colleagues who want a second round with this panel before I release them, can you please raise a blue hand so that I can go to you right after Mr. Bach presents?
So first of all, Councilor Arroyo and Councilor Janey, thank you for inviting us tonight. And I also just want to say I really appreciate the tenor of the conversation. You know, folks who are on Mass and Cass aren't choosing suffering, and so really appreciate the thoughtfulness in the way you've approached this hearing. Just to share with you, our program's been in the South End for the past 35 years. We're a private nonprofit, but we work incredibly closely with, when Councilor Baker was talking about, or I guess it was Councilor Flynn talking about Jim Green and Jim Hooley, I just felt old because I've been working with Jim. We started right around the same time doing this work 35 years ago. So we're a primary care practice, and embedded within our primary care practice is really focused on mental illness and addiction. Leading cause of death for the folks that we serve has been opioid overdose, and that's going back 15 years now. And so we've worked hard at really trying to reach people in different ways in terms of both treatment and harm reduction. And we have a very large street outreach. So in addition to our work around Mass and Cass, we're also down around the Boston Common. We're partnering with Bridge Over Troubled Waters, and we have a practice in Nubian Square as well. It's come up several times just in terms of what's been going on in terms of COVID. We've been doing the universal testing in the shelters, and as I think the council is aware, early in March, we were finding, almost 40% of people that we were testing were positive. I think that Sheila may have spoken about, that number, thankfully right now is fairly low. And over the last 4 weeks, it's ranged from 0 to 10%. But most recent testing just last week was at around 2%. So really fortunate right now. And my hats off to the shelter system and our city partners in terms of decongestion of the shelters. We also operated 600 plus beds during the first surge. So we're hoping not to sort of go there again. And I guess just the closing piece that I would like to say just is, that as I've listened to the panelists and as folks are talking, I think Boston, though we have a lot of work to do, I think there's a lot to be proud of. We're thankfully not Portland and Seattle and San Francisco. I think that the good work that the city has done, really, I'm proud to call you all my city councilors. I live in Boston. So I think that there's been really efforts that are unique to us as a large city. And, this has been a national failure that, based on, a system that promotes poverty and racism and has underfunded mental health services and underfunded very low income housing and underfunded addiction services. And so we're finding ourselves in a position of trying to, where we're so far behind and trying to play catch up before we can get ahead of this. And I think that we as a city have done a really solid job on that, and still lots of work to do. But thank you for giving me the time. Appreciate it.
Thank you, sir. And thank you for your patience, everyone. I'm now going to do a brief second round. I see Councilor Baker. I see your hand up.
Hi, sorry, you just caught me when I stepped away. But anyways, Kim, can you drill down on some of those Councilor Arroyo had cited a study on Section 35s, but it seems like it's people coming out of incarceration in Section 35. Is that the case there? So that would be a skewed number?
Counselor, I don't know if I'm the right person to ask
Oh,
that
okay.
question.
Maybe
I
Jen.
think
Jen, are you
Jen
familiar
or
with that?
Sergeant Messina.
If I could jump in, Councilor Baker, we do have folks on the second panel who can speak to the Section 35s as well.
But they're gonna all be anti-Section 35, with all due respect. You know what I'm saying? We're dealing with all.
I mean,
the
I don't think facts
panel,
are.
the next panel coming up is gonna be safe injection sites, which are the
Let us speak first.
in
before you-
anti-Section 35s.
And so I'm Councilor Baker, I'm happy to let them speak for themselves. But what I will say is, the data, just so you understand, Section 35s are involuntary holdings.
I know exactly what they are. I've done plenty of them myself.
Any other name. So if you call a Section 35, they're not. Section 35 is not the same as serving a prison sentence. So it's not incarceration in that sense. The Section 35 and the data that came for that comes specifically from Section 35s. But if any of the panelists would like to
No, but I thought I heard it was Section 35s, including people being let out of straight incarceration. That's two different populations.
If anybody would like to address that on the first
Well,
panel.
if you want to wait till the next panel, that's fine. But again, the next panel is going to be skewed towards.
No, I'm happy to if anybody here wants to speak to that for Councilor Baker, please do feel free.
I'll just reiterate what Barry said. It's around someone's tolerance and people's tolerance when they're in treatment, even in treatment, but involuntarily committed. Their tolerance is down, and so when they come out and they use again, the likelihood of fatal overdose.
But is it more,
increases.
Jen? Is it more with Section 35 than going into regular treatment?
I will. I would refer everyone to Chapter 55 data on the mass.gov DPH website for the facts. I don't have it in front of me.
Well, it sounded like it was cited that they're lumping in Section 35 with people coming out of regular incarceration.
They've been looked at separately.
Okay, thank you.
It was that it, Councilor Baker, or do you have any other questions?
Yeah, well, Peter Messina, can someone section themselves? Can they be asked to be sectioned? Is Peter still on?
Hi. No, they cannot section themselves. But what we're getting is people are asking us to be sectioned. And we're working with the families as well. So I have, like I said, countless success stories where individuals are coming to us saying, I can't do it without a section. I need to be sectioned. Please help me. So we're working with that individual and working with our partners to provide enough information to the courts, help that individual out.
Okay, thank you. Thank you.
Thank you. Councilor Asabi George.
Thank you again, Mr. Chair. I don't have a question. I just really want to make a comment and thank everyone who's presented today and who's shared their work. I know Barry just wrapped up, but I do want to, through Barry, just thank some of his team that is out and about doing a tremendous amount of work. Many, I guess, pre-COVID, last January, I did a ride along with the Squad 80 crew. And, I've gotten to know the BPD outreach team quite a bit over the last couple of years in particular, but through that morning really saw up close in a different way than I've seen just through my work on the council, some of the efforts that are happening through Barry's crew, the Healthcare for the Homeless and their work on the street and in our communities. But for everybody that I'm looking at on this screen, the work that the city's doing, the work that the Health Commission is doing, the work that AHOPE's doing, the work that the Mobile Sharps team is doing, it is really a tremendous effort. And everyone is in the Boston Public Schools and everyone is responding to this urgent crisis. I think that we all agree we need so much more help. We need so much more help to really face this, this critical time on our streets and in our neighborhoods and to help those that need the most help. and to also make sure that we're responding to the needs of our neighborhood and our residents and our businesses. So I know everybody on here is working tirelessly, especially during this time, to help some of our most vulnerable residents, those that are unsheltered and those that are trying to access services across our city. And everyone recognizes the impact it has on our neighborhoods, on our residents, and on our businesses. So I just wanted to just share some appreciation and gratefulness for all those efforts. Thank you, Mr. Chair.
Thank you, Councilor Sabi George. President Janey.
Thank you so much, Mr. Chair, and I certainly echo the thanks from Councilor Sabi George to everyone on this panel. Just a few questions, because I know that the hour is late. We've got a second panel. We've got folks who want to testify. One thing that I did want to do is get some questions into the public record. There are a number of questions that have come from the South End Roxbury Community Partnership. Mr. Chair, would you like those to just be submitted to you as chair of the committee? But these are questions that we hope to get a response from the administration. So what's the best way to facilitate that? I can read through them, but it's a page of questions. So I don't want to take unnecessary time. And I do have some questions of my own. These are data request questions. So I don't anticipate that anyone will have a response, which is why I want to get them formally on the record through you as chair, but I don't have to read them and take the time because I'm not expecting.
No, I believe I can send that over as a
exactly
hearing too.
Because I want it to be part of the public record, and I want there to be an actual response. And when I asked an earlier question around some of the data points that I was looking for by race and ethnicity and by zip code, I don't think we're going to have answers to this, and a lot of these questions are asking for that kind of
so
data.
We can send this as a committee info request, and that will be
so I will submit this to you so that we can do that through the committee.
And we will do that.
I do have a few questions of my own. I wanted to direct around housing, and I appreciate again having the fullness of this panel here, because this isn't just Kim Tai and your team, but we've got to make sure that there is that coordination. And in fact, the coordination was a big theme on our walk this morning when we did the walk, the safety walk earlier today. I did have just a few questions on the housing front. You talked about some units being in the pipeline and units already existing. I would really like to understand, as we're talking about decentralizing and making sure that there's equitable access, where these units are. If you said it earlier, I'm sorry, I missed it. The same thing in terms of treatment beds and new places that are offering services. We are saying that we're decentralizing them. And I think for me, what would be helpful is more than just a list of sites. I would like to see this on a map. So if we are truly decentralizing them, the way to measure our success is to see how this is playing out with dots on the map. And so if, Sheila, if you just want to briefly respond around the housing, but I would ask respectfully for future that we have the treatment beds, the services, the housing, when we're talking about decentralizing them, just to visualize it for us to see that on a map.
Sure, and we can map this, Councilor Jane. At least we can map the housing, and I'm sure we can work with Boston Public Health Commission and do the treatment as well. So, and I can follow up with you in your office too to see what, do you want all affordable housing? Because we use all affordable housing for folks that are homeless. The BHA, they give prioritization to individuals and families that are homeless. So so we can follow up with your staff to find out what would be the most useful, or do you want just housing units that are dedicated to the, only dedicated to the homeless? So why don't I follow up with you tomorrow and your staff, and then we'll get you exactly the map that you want.
Excellent, excellent. And I think for everything in terms of the data, really helpful to measure our success. I wanted to make sure to mention gender again as well. I know I said race, ethnicity, and zip code, but I want to put gender in there as well. And I share the concern that Councilor Sabi George lifted up earlier around how women are being impacted by this, which is why I want to understand how we're engaging women particularly when it's violence against women. I'm not going to ask a bunch of questions here. Again, I know the hour is late, but I did want to, again, just extend my deep gratitude for everyone and sharing about the work and some of the challenges, but also the opportunities that are before us. I think it's important that we do a much more regular check-in on this issue. And I know that there's a task force doing good work and that there are colleagues on the task force, that's great. But I think that the council as a whole should also be following this up. And so I look forward to working with my colleagues who prioritize this issue. And I know we all do, but I know folks have been leading in this space, like Councilor Sabi George, certainly my colleagues who represent this area, Councilor Flynn and Councilor Baker, and certainly the chair of this committee of public health, Councilor Arroyo, as well as many others, and certainly all of the various departments represented here. Again, I want to stress the importance of coordination in terms of our approach, really trying to understand the root causes of why people are self-medicating and why we see what we see, because until we get at that root cause, we can't really get to the stabilization that Councilor Arroyo is speaking to. And even when we see areas that are cleaned up and looking better and on the walk, there was a lot to be proud of on the walk today. But, you know, as I said several times on the walk today, it's not like people magically got housing or got jobs or got well in terms of addiction, or restored relationships in terms of family members and friends and their professional networks, etc. So this is a long, hard road, and I'm just grateful that people are in it. And I would ask that we continue to check in. Thank you, Mr. Chair. I am anxious to get to the next panel.
Thank you much, President Janey. I'm going to actually just send in with those questions, my second round questions, so that we can move forward. So if you are here on the first panel and you would like to leave, please feel free. If you would like to stay, please feel free. But we're going to start with the second panel now. And in that panel for folks here, Casey Hurd from the Executive Director at Material Aid and Advocacy Program, Dan Hogan at Codman Square Health Center, and Jessica Gallagher from the Committee for Public Counsel Services. And if you can go ahead and just give your opening in that order, and then we'll open it up to the council again. Thank you. Sorry, Cassie, not Casey. Sorry, it's been a long night. Cassie.
Hi. So, I mean, I think I want to just like sort of reiterate something Leo had mentioned. That, you know, to my knowledge, this hearing is absent of the voices, experiences, and expertise of, you know, the people who are closest to the pain and closest to the problem, the most impacted and harmed, both by homelessness, substance use disorder, and the way we are addressing it in this plan, which is, you know, just a continuation of Operation Clean Sweep with a different name, you know, having been rebranded. And so I want to share a little bit, like Councilor Laura, thank you so much. I know we tried to have the voices of people who are unhoused at this meeting, and I appreciate you trying to be flexible and accommodating people beyond the sort of technological barriers a meeting like this brings. And folks I work with, and I spoke with several unhoused community members about attending to testify, and it wasn't the technological barrier and technology barrier of coming. Many folks cited that just the time of this meeting is when the police really ramp up their sort of daily sweeps of people from the community, and people were going to have to really focus on where they were going to be. And so when the option of either preventing video or audio testimony was brought up to folks, people really just said that because of the increased surveillance, both by police and community members, they did not feel comfortable being on this call, that they're consistently surveilled, that they're viewed, that people really are ostracizing them further and causing harm, and that this was not a table that they could come to and feel safe or comfortable. I think we do know that unhoused people who use drugs are both the authority and experts and have the solutions to these problems and should be at these tables. So I think we all need to think about how we can engage people to bring their expertise, to bring the solutions that are based in evidence, housing, healthcare, harm reduction to this plan or to a new plan that would not be as police and public works oriented. And know that the people who we're talking about now, instead of talking with, are not a monolith, and we can't have one person representing an entire group of people. With that being said, I'm going to then contradict myself and share a quote from someone who is very important to many communities and who was a close friend and organizer. She sat on the task force for Mass and Cass, was the founder of CFMA Now and the Boston Union, Aubrey Esters. She passed away in June of a stroke, but she had a wonderful quote that I think speaks to this meeting, even though it is a year and some change. I believe it's day 464 of Operation Clean Sweep, because to be clear, this plan is a continuation of Operation Clean Sweep that just criminalizes and moves people along, offering little tangible solutions to homelessness, substance use disorder. So yes, I will share. So Aubrey said the hundreds of people who are surviving poverty and living in our neighborhood have few, if any, safe spaces where they can simply exist throughout the day and night and are being forced to move from corner to corner, from the street to street every few minutes of every day. The combined atmosphere of insecurity, anxiety, harassment, and hopelessness for many of our houseless neighbors needs to end. I want to say that there has been much talk about engaging people, as I noted before, and it was noted that there is some engagement with people. To my knowledge, there has not been another drug user added to the task force or a person who has lived experience. So I would urge the administration to add someone, more than one person, to the task force as soon as possible. And so I want to just address like some things that have been brought up in the meeting. I had some testimony, but I think we'll throw it out the window. So at the opening, councilors sort of expressed frustration and concern, some confusion, it seems, around why the situation hasn't improved. And as I've said before, the plan sort of is not rooted in evidence-based solutions, right? It's sort of rooted in like the criminalization and coercion of people, as Leo noted. And these have been disproven. Their effectiveness has been disproven in other cities. San Francisco was cited, Los Angeles was cited. There's been no evidence to show success. I think, people have been talking about like creative strategies being needed or innovation, but we don't need new, we need things that are based in evidence, right? So Sheila noted there is some low threshold housing available, but we need low threshold housing that, uses like real housing first strategies and doesn't require sobriety and has a continuum of care that comes along with it, that, is from trusted providers that are community based. And aren't necessarily the ones that are the major partners of the city, right? Who have caused harm to people, who have barred them, who do not allow them to be part of their services. Extending shelters to housing is not effective, right? We need healthcare, that means treatment on demand. That means a whole continuum, much of what healthcare for the homeless provides. But we also need to both expand the harm reduction we have, but also, as Leo said, look to evidence, look to where, there has been success in that safe consumption sites, right? There's never been a single death at a safe consumption site. And the ICER study that has been going around showed that overdose deaths in the immediate area around an SCS would have gone down by a quarter, and we would save $4 million in the city of Boston. That money could go towards treatment. So if and when someone decided for themselves that they wanted to access treatment, and that can mean a whole lot of different things, right? That can mean treatment that is assisted by medication, that's the gold standard, right? And people have significantly more success it an abstinence-based treatment, that they could access it right then in the moment that they wanted to access it. And it wouldn't be waiting for days or weeks. And I heard, officer, I'm sorry, I don't know your name, mention that people are sectioning themselves or wanting to section themselves if that were to be available to them. But in the many people that I talk to who either have been sectioned or are considering being sectioned, or, it is because there's no treatment available to them other than that. And it is not an option that people want to pursue. I've known a few people who have done it, with a family member in partnership, and it has never been what they wanted. 2 of the 3 facilities in Massachusetts where men are sectioned are jails. You're just putting people into a situation, of incarceration by another name, and it is not to be proven an success. Leo, who had been on the call, could speak better to Councillor Baker's question around sectioning. He was on the Chapter 55 commission, and I'm sure you could reach out. But there is a significant increase in overdose death following being sectioned, because it was not, for both, the issues that have been noted around reduced, people have been abstaining from use, but also because it was not of someone's choice. They are not given supportive services after, and it's not a rehabilitative and an environment that fosters health and wellness, right? You're in a jail. And so people aren't provided resources or care that they need to be successful. And I want to just say again, policing should not be sort of any part of a plan. It should be a public health plan. We're utilizing many sorts of softer policing in this plan, like from therapeutic policing that sort of is coercive and further embeds police into outreach and recovery. That has been shown to not work in San Francisco and LA. The relationship with police, puts people in a situation where they're both being penalized by an officer, but then, having to see them as a provider. And it doesn't tend to foster success, and evidence has shown it doesn't. And, the sort of complaint-oriented policing that relies on community members, both housed, business improvement districts, businesses, neighborhood groups, as partners in policing and partners in criminalization, has been shown to not be successful. San Francisco is walking back their use of 311 because it has been nothing but, a cost, and sort of the commissioner of police in San Francisco referred to it as whack-a-mole. And their Patrolmen's Association made a statement in February requesting removal from the process, and that they felt it should be a non-police outreach strategy because, as they said, it's a costly revolving door, better at moving homeless people endlessly than helping them exit homelessness. And I want to speak a little bit to the encampment and the redirecting of encampments. It's another strategy that I think it's been insinuated that it doesn't work. And Councillor Roy talked about seeing people returning to neighborhoods. Councillor Flaherty talked about encampments popping up in his neighborhood, but that's the direct result of moving encampments, right? It's not like people are moved directly into housing from encampments. They're just being moved along. And to share a little bit about an encampment, I was at the first answer Operation Clean Sweep, but also at the request of community members who come for support and are organizing partners at the Material Aid and Advocacy Program. I was at the encampment sweep to provide support, offer some resources, and just help people move their things that Jim Green mentioned. It was largely run by police. There were a few workers there from Pine Street. People were being moved along. The only services they were offered was night-to-night shelter. Many of the folks noted that they'd been barred to the shelter that was being offered, so they were actually being offered nothing. It may look better and feel better for those of us who are not experiencing in an Operation Clean Sweep. It's not sort of the overt policing of people, but it's still moving people along from a community that is there to care for each other, that is known to service providers, where people can come and do meaningful outreach, and access care. And we know that sweeping encampments has a huge negative impact on people who'd been residents of them. There's an increase in overdose risk because people are no longer with their peers who are most likely and are the first responders to overdose. You know, medical providers outreach. When I was there, 3 separate Boston Public Health Commission outreach people came over and asked what was happening and had been entirely unaware that the sweep was planned. It took several hours. They came, you know, one guy was the replacement for the shift before him and just had no idea. So I think to sort of frame it that this is like service oriented is completely false. And I want to note that there were several, you know, folks who were moved along, but I think the folks that were having the most challenging time with it were 3 young Black men from Roxbury who grew up just outside Dudley Square. And one of them noted that he'd been displaced and just was in disbelief that he was being displaced from his community entirely. You know, he'd been moved out of his home, but now he was being moved out of his home, like homeless encampment. And he was trying to stay as close as he could to his community and just was being told that he was very overtly not welcome there. And they just had such a challenging time. And I think it's, you know, no coincidence that there were 3 young Black men. You know, we know, you know, the U.S. affordable housing and homeless crisis disproportionately impacts, you know, Black and brown communities, and Boston Black people are disproportionately represented among those experiencing homelessness. And they'd also experienced incarceration, which is just perpetuating, you know, homelessness by then criminalizing them again, which we're doing with this plan. So I think I've gone on for a while, but I just want to say that there are solutions and they are based in evidence, and we're not pursuing them enough. And I think it's not thinking out of the box or innovating. It's going back to what's based in evidence, and will actually get people housing, healthcare, and harm reduction and be better for our community as a whole. Thank you.
Thank you so much for that. And I will certainly have follow-up questions. If next we can have, let me just see who we have. Dan Hogan, if you can go next.
Hi, thanks everyone for giving me the space to speak. I'm a clinician at Codman Square Health Center in Dorchester, and I've been working in addictions for about 20 years now in various capacities, but as a social worker since 2012 when I worked with Barry at Healthcare for the Homeless. The community I work in is a community that has long struggled with addiction since the 1960s and 1970s. Anyone who's from Boston can remember what kind of went on in Dorchester, Roxbury during that time. And during that time, there was a wave of overdoses from heroin. Subsequently, the crack epidemic came through, and those public health issues were largely ignored. When services started showing up in the community that I work in, it was when people that look like me started overdosing. The services that we offer there are a range, everything from Suboxone to Vivitrol, psychotherapy, case management. We have multidisciplinary teams of doctors, nurses, social workers, case managers, peers that are all involved in this process. In order to get someone into treatment, we cannot directly refer into the treatment system. We have to send that person to an emergency room, or we have to send them down to Mass and Cass in order to get connected to services from there to then go into a treatment setting. And I'm talking more about residential treatment, not from, detox is often self-referred, but there's a lot of loss to follow up. This is one of the themes of this meeting that I hear is how many different things are all going on, how much effort, how much work people are putting in to do all these different things. And yet this crisis continues to grow. So the last time I went into treatment for heroin addiction, I was homeless in 2008. The financial crisis was happening. And November 4th, 2008, I was able to get a bed at Danvers Detox. And Barack Obama was accepting the presidency that night. I was sitting in the intake room, listening to him talk about change. And I knew that was a motivator for me. That was something that message that he was speaking about motivated me, that I needed to be an agent of change in the system. And I paid attention as I went from detox to a TSS, to a halfway house, what the system was like, where the shortcomings were. And there were many. I also learned that a lot of the information that I got that helped me along my way were from my peers, the people around me, the people with lived experience. I was lucky. At that point, it was much easier to get into long-term treatment. You went to a detox, you still had a very low chance of going on to further treatment, but it was much better than it is now. Now I have many patients that go in and out, in and out. And the reason long-term treatment was so important, if we think about Abraham Maslow, right, humanistic psychologist from the mid-20th century, he talked about hierarchy of needs. At our basis of those needs are our safety and physiological needs. If those things are jeopardized, which anyone on mass and cash right now, those needs are always in jeopardy. There is no way that you can focus on your self-esteem or your role in society. You're just trying to survive. And it's taking a tremendous amount of psychological effort to do that. Residential treatment provided me with that stuff. It allowed me to clear my head up long enough to realize that I needed to start to work on myself and get access to recovery. What we need is an integrated network of systems. We're talking about decentralization. I get that that means moving this issue away from that area. And I actually agree with that. And to, sort of the comment about Section 35 that Councilman Baker made earlier, I think we need to actually rethink Section 35 as a policy and start thinking about what is a modern way to do this, because the answers to our problem actually exist in our own history. 150 years ago, almost 200 years ago now, Thomas Kirkbride and Dorothea Dix advocated actually to the Massachusetts state legislature about the need for centralized hospitals that people could go to get support. And their idea was that you get people out of cities and put them into, sort of the countryside, away from the stress of urban life, let them recover like we all do when we go on vacation to get away from Boston. I go to the Cape, people go out to Western Mass, out to the Berkshires, wherever. You get away from the city because it's stressful. The idea was to give people access to fresh air and sunlight. And while they were there, give them roles, give them jobs, let them work on the farm, let them be part of the store at the hospital. These were all designed to give people a sense of purpose and meaning. Now, we probably all remember that these hospitals were hellholes. Well, why was that? It's because we didn't fund them very well, because we didn't staff them very well, and because we overcrowded them. Guys, this problem is not going away. Do we need supervised injection sites? Yeah, absolutely. We absolutely need places that people can use, and because that's not going to stop. And we need people to have pathways to recovery from those places, because you can have a good relationship all you want with the community health worker or the public health worker that you see there, but if you can't get a bed, tomorrow is a completely different day. I think that we're looking at this issue. The suffering that is at the core of all this is one that's profound. And I can say that as someone who has suffered in that way, who understands that fundamentally. We are dealing with a massive amount of trauma that is happening generation to generation. Okay, so people on mass and caps are having children. Those children are growing up in poverty, in addiction, right? Or they're growing up in the system. All of that is trauma. It's really hard too, because all of our staff, all of the workers that we have throughout the system are burning out, and especially with COVID, it's incredible. We're in a really dire time right now, and that means we need to start really moving more quickly with some of this stuff. It's almost 9 o'clock at night, right? How long have we talked about data and all this stuff? And I know that that's important, but why is it that the people that are most connected to this work are speaking at 9 o'clock at night? I think we have to listen to the notion that the people that are closest to this are given the least voice. We need more people involved. Just like if you were a business that was trying to sell a product to someone, you would do focus groups. You would have consumers that would be involved in that process, right? We need to do more of that. The way to motivate people into treatment, give them access to safe places to sleep, give them a sense of value and purpose, and allow them to have some access to hope. Let them know that there is a pathway. And this is all stuff that has been done in various ways, and that is currently being done in all these different silos throughout our state and nation. If we were able to start bringing those services together under one roof, where the state could oversee that or the city could oversee that, I think we would be on the right path. But that's just my perspective. So I want to thank you for letting me speak, and I really appreciate that this topic is such an important one, because it certainly is. Thanks.
Thank you, Mr. Hogan. And finally, Attorney Gallagher.
Yes, thank you, City Councilor Arroyo, for inviting me to speak today, and thank you to everyone else who's already spoken. So I work for the Committee for Public Counsel Services as a public defender. I've been there for about 8 years. And during that time, I've handled about 100 Section 35 hearings. As a public defender, I have seen the tragedy of substance use disorder, and I care as much as anyone does about the health and safety of my clients. But I know from anecdotal experience that Section 35s do not work, and the data suggests that it can be really harmful to people. Section 35s are not proven to succeed, and there is some evidence to suggest that it can actually increase a person's risk of overdose, as was previously mentioned here. Currently, there is no data coming out of any facility about the COVID rates or protocols, and I appreciate Sergeant Messina saying that they use them as a last resort, because they definitely should be a tool of last resort. I would like to give some clarity as to what Section 35s are in terms of the legal side of it, because I don't think that's actually been addressed yet. So under the statute, there's 2 prongs that have to be met for someone to be committed under Section 35. And I get that it's almost 9 o'clock and I don't want to shout a bunch of legal jargon at you. So I'm going to make this as quick as I can. So the first prong is that the person is a substance user or alcoholic as defined by the statute. And this basically means somebody who is using a lot, using every day, but it's also someone whose use is substantially injuring their health or substantially interfering with their social or economic functioning, or that they've lost the power of control. So all of that is the first part. The second part is also that the person is at serious risk of imminent harm to themselves or to someone else. And proof of someone's use by itself is never enough to commit someone, no matter how much they're using. The Supreme Judicial Court has actually said that anybody who qualifies as a substance user under the first part is at risk of overdose, just by definition. And there must be additional strong and specific evidence presented that their risk of overdose is indeed imminent, and that the degree of probability that they will actually overdose is high. Sergeant Messina talked a little bit about the process of a Section 35, and I don't want to repeat what he's already said, but I would just like to point out that when someone is brought in on a Section 35, they are handcuffed, they are brought into lockup of the courthouse, where they frequently wait in a cell for most of the day before they see a judge. A lot of times they don't know what's going on, they don't know why they've been arrested, and it can be very traumatizing. If they are committed to a facility, which they frequently are, they're forced to undergo a detox. And as we know, some of these facilities are run in jail settings. It's not the same as going to a voluntary inpatient residential program. It's a carceral setting where they're forced to detox. And the facilities that are operated out of these jails often treat our patients and clients like criminals. This can include solitary confinement and strip searches, and this is obviously not therapeutic and possibly unconstitutional. Typically after detox, they can engage with caseworkers and do whatever programming is available to them if they choose to do so. The average length of commitment is usually around 24 days, and the majority of people who are sectioned are released with no follow-up plan for treatment. In my experience, those who are sectioned end up being sectioned again and again, and this makes sense. Most of us know that if you want to enter recovery, you have to want to do it to be successful. And that's why Section 35s are frequently not helpful and often can be more harmful than helpful in terms of the risk of overdose. I would actually like to speak to the data that Councilor Baker brought up earlier. It's the Chapter 55 report, and the direct quote is that clients who receive involuntary treatment were 2.2 times as likely to die of an opioid-related overdose and 1.9 times as likely to die of any cause compared to those with a history of voluntary treatment only. And that's on page 49 if anyone wants to check that. As some of you probably know, Governor Baker established a Section 35 commission back in 2018, and their report was published in July of last year. I would really encourage anyone to read this report. It has a lot of helpful information and other data points about Section 35s. The report specifically talks about studying the effectiveness of these commitments, but it's extremely hard to do so for a whole host of reasons. However, the majority of studies they do cite state that all of the studies failed to detect any significant positive impacts on drug use or criminal recidivism over other approaches. COVID has obviously made these commitments even worse for those who find themselves sectioned. Currently, the Massachusetts Alcohol and Substance Abuse Center, often called MASAC, has a COVID outbreak. And as far as I know, they are still not taking any new commitments right now. COVID and social distancing guidelines also affect what kind of programming these facilities can do, and it has been heavily reduced at most facilities. The Supreme Judicial Court recently recognized that because of COVID, judges now must make a separate determination about the risk of harm to the person actually being sent to these facilities, meaning their risk of harm from contracting COVID. As such, as Sergeant Messina said, sections should be a tool of last resort. And again, those are not just my words or Sergeant Messina's, that's actually a quote from the Supreme Judicial Court in that case. While I certainly understand the purpose of Section 35s, they're frequently traumatizing to those who are forced to undergo them. And in my experience, they are not a solution to the epidemic that our city currently faces. And I just want to thank everyone again for the time to speak. And that's all I have.
Thank you, Attorney Gallagher. And with that, I'm going to hand it over to my colleagues. President Janey.
Thank you. Thank you so much. I want to thank everyone on this panel. I know Leo already had to leave. He presented earlier, but thank you, Cassie, Dan, and Jessica for your testimony. I'm interested, Cassie, you were listing a bunch of things. I heard you say safe consumption, certainly not to treat that this is a public health issue. I think people agree to that point, at least, and that this should be treated as such in terms of the response, and that from your perspective, too many police. I wanted to make sure that I was hearing some of the other solutions, if you could just enumerate them quickly. So I heard the safe consumption.
Yep.
Yep.
Sure. So I think a lot of it is like, based in these three, like healthcare, housing, harm reduction.
Okay.
And like I talked about how housing should be low threshold. It likely shouldn't be associated with any sort of shelter system, because that's just a continuation of the shelter systems. That's not meaningful long-term housing.
And do you have any specifics about how we would get there? And so when you say getting people into housing, and what I heard you say in your presentation is that you were worried that too much of the Melnia-Cass plan is just like the Operation Clean Sweep when everything happened down at the jails. Can you speak specifically in your mind what the appropriate engagement would be from your perspective in terms of really getting people from the street or from a tent into permanent housing?
Yeah, so I think like the first step is like removing police from this response, right? It should not be a police-led response. It should be a public health response. And to do so, you need like an expansion of harm reduction, an expansion of, peers who have been trained up to support folks who have been through this experience before. And you need to have sort of like the resources to do so. And that obviously can be like transferred from one system to another, right? Different places who have had success in sort of housing people from the street, right? Into like, usually it's with an SRO, usually it's transitional here in Massachusetts, and widely we've moved away from that. Those like systems of transitional housing. But in Canada, they still use them. There's been like SROs, where people are still sort of with peers and sort of like have some privacy, but have a community setting where they can sort of be and access services on site. And in Canada, those include harm reduction services, and some of them include safe consumption sites. In Vancouver, they do. And they sort of are placed where they are needed. There, it was sort of convenient because they had vacant hotels, and it's sort of like transitioned. There are some cities in the U.S. and there's at
and
least
we have that here. So I assume that Pine Street is taking over one of the hotels here to do the same thing here.
Well, so they're just using it as a 1-year shelter, correct?
Right. Yes, just a 1 year. It's just a 1 year. And in fact, I would be interested in your perspective from residents and business owners in terms of that many feeling like, while wanting to be very compassionate as people are dealing with this issue, but for them feeling like this is a lot on their shoulders. And so, whether it's safe consumption, whether it's transitional housing, whatever the issue, what we find in Boston, so I can't speak to what you found in Canada, but you're going to find a lot of folks who are going to say, not in my backyard. And, or just disagree with it outright. Maybe they don't have the data that you have, but what do you say to neighbors and business owners who have historically for years? And I know Mr. Hogan, said that this issue was ignored. The public health issue was ignored in the 80s when it was Black people. It wasn't ignored, it was criminalized. And people were thrown in jail. And the effects and impact of that is still being felt and will continue to be felt for generations to come, quite frankly. And this COVID, opioid, and everything else is compounding that existing trauma for residents, whether or not they have substance use disorder. And that it's very complex because these are, I think someone said it earlier, these are, in some instances, friends, people, some folks who are out here. I certainly, I'll speak for myself. I have people in my circle, in my family. I mean, my uncle died from a drug overdose, was found with a needle in his arm. So this, this issue it's a very complex issue. And so I just want to hear briefly, anyone, I don't want to just pick on Cassie, anyone can speak from the perspective, because what I hear is a very compassionate approach, which I appreciate, a public health approach, which it has to be. Certainly one that is not one that is about policing. I would agree with that. This is a public health issue. But I think for residents and business owners, there's still a lot of frustration. And even if these are solutions that folks are saying would work, like safe consumption, the big fight's going to be where you're going to put it.
Right.
Anyone can speak to that? Anyone. I don't want to, just you, Cassie. Anyone can speak to it.
I think if I can just respond very briefly, I think that is one part of a solution, right? And I think I want to acknowledge what you're saying, and it is, the war on drugs is a war on people, but the war on drugs is specifically a war on Black people, right? And I think we should not perpetuate or duplicate systems of harm, right? It is proven to be harmful. And I think, this plan, is sort of replicating that system, right? And engaging the police as public health workers, which that is not what they're trained to do. And yes, there can be some training, but there are other systems of care that are based in community that would be more successful and have been shown success. And I think if we can have conversations broadly with community and help people understand, what people's needs are and what solutions that have been based in evidence, but they're also self-identified, right, by the people who are most impacted, those people who are unhoused, people who have substance use disorder, or might be a person who uses drugs, who don't identify as someone who has chaotic, or a dependency, right? But that also, that's when we will find the most success as a community, right? When we have these strategies that people are seeking, and if we provide those, they'll be more likely to use them, right? Instead of sort of coercing people into these non-evidence-based, non-solutions, I would say, right? And certainly there are parts of this plan that are, components of a solution, right? But if we don't have something that's encompassing, then it's not going to be successful. And we're still going to see people out there, and it's still going to, make people uncomfortable, or, I can think the sharps problem, right? I've talked with folks who are but I don't want public sharps containers. I don't like that. I feel like enables. Well, if our big challenge is having sharps, having disposal kiosks for people to put those sharps, I think it's really having conversations around what potential solutions are. Yes, they might not feel good on upon introduction to them, but understanding how they could sort of address parts of this, large problem that people who are unhoused, people who have substance use disorder, and people who are in that area most acutely are experiencing, but also that it's the broader community as well.
Yeah, Kim, I wanted to acknowledge what you just said earlier about, and Cassie, I think that was a great response. And when you were talking about the criminalization of the communities, I had that actually in my notes, and I got nervous when I started speaking to not acknowledge that that's largely been the way that we've responded to drugs, is by like cracking down, you know, especially when it's a community that has historically been, you know, been targeted in that way. It's drugs have just been an avenue to do that. Can we get rid of police? I don't know. Honestly, I don't know that like that's really a good plan either, right? We can't just completely eliminate policing from any of this because there are safety concerns. When I was growing up, I played a lot of role-playing games, Dungeons and Dragons, stuff like that, right? And bear with me for this example, but one of the things you had in a role-playing game, right? You had to have like a soldier, you had to have like a wizard, you had to have a cleric, you had to have different roles that were all part of the same party, and together you all sort of offset one another. So some people brought strength, some people brought the ability to heal, that kind of stuff, right? So let's take that into a real world example. Why aren't we pairing police with social workers, with nurses into like little squads that are then as groups responding to these things together in tandem, where everyone's using their resources, and then depending on what that problem or that situation might need, that person can step up while the other people step back. There's another version of this, the Department of Public Safety model that other municipalities use, where you have police, fire, EMS, all cross-trained, and then certain people take different like roles in those departments. You might have someone who's a firefighter as their predominant role, but they're backing up a police officer on a call in that way, where it, depending on the need of that situation, you're able to respond in different ways. I think that's part of what, you know, needs to happen is, you know, we need to be utilizing all these resources. There's a lot of information that police have. There's a lot of relationships and also like security offerings that police have that as a social worker, I don't want to get sent out into a hostile environment that I don't know, that I don't have relationships with, and asked to address this huge problem. So you all, you know, we need to find ways to sort of combine some of these things. And then we need to offer services that people want, that are desirable.
Mr. Chair, I know the hour is late, and I know other colleagues have to speak, and I don't know who's next in the queue, but I know some of the things that you were just listing is happening, but I'm going to defer, Mr. Chair, so that we can get on. I know it's after 9 here.
Thank you, Council President Janney. Just so people know what the order is, Mejia, followed by Councilor Asabi George, followed by Councilor Baker. So Councilor Mejia, the floor is yours.
Yes, thank you, Chair Arroyo. I'm going to recognize that we haven't heard from the public yet. And I really do appreciate the panels that we've had so far. And I am curious to hear, I know there's one panelist who is a teenager and she should be going to bed soon, but I believe she's still waiting to be heard. I see her little blue hand up in here in the panelist attendees column. And so I just really would be super mindful of how I utilize my time and privilege of being a city councilor. And I will actually defer my time so that I can allow the people who have been waiting for so long to speak. So that's all I have to say.
So maybe Councilor Arroyo stepped away. It's my turn next.
No, I'm here, but we got you next. You can go right in.
Great. Thank you, Chair Arroyo. I'm thanking my colleagues and Dan and Cassie and Jessica, thanks for your testimony today. I do want to just say and reiterate with what Councilor Janney just mentioned, a lot of what Dan was talking about, we've been doing, some of it we've been doing, and we've increased our capacity to do more and to do better here in the city, both when it comes to fire, EMS, and police, but also the co-responder model and making sure that our co-responders, our clinicians, have an opportunity to also do some proactive work as opposed to just simply co-response. There's a lot of thought and thoughtfulness going into the work around planning for the work of these additional 15 clinicians that the city is currently onboarding in partnership with BMC. So that's really exciting to hear that it's something that you're looking for more of, and it's part of what we're doing as a city. And I also want to just echo the Sharps containers, just as an example. Cassie brought up, we will very soon see 100 additional kiosks across the city, because this is certainly a problem when we think about improperly discarded needles across the city. So that's for sure. I would like to hear from this panel if they have any thoughts or suggestions of cities in the United States in particular, because we know some of the stuff that's happening internationally, but what in the United States is happening that we should be looking to replicate or have reflect in our work here in the city. Who's doing good stuff and where?
I think there's a reason for silence, because sort of, in at least a dozen cities across the country, the major response is sort of similar to this, a coordinated response that includes police that's largely unsuccessful. But I think that doesn't mean that like the pieces that bring success can't be put together as
So are there some examples of some of those pieces of success in other places?
Yeah, I mean, I think like I've been, saying if we have like lower threshold housing that has supportive services that is not abstinence based, right? That we like a true housing first model. If we have comprehensive healthcare available to community members. But a lot of it really is that like removal of like the element of criminalization and moving people along that is just counterproductive. People don't get to spend their time thinking about what positive changes they could make in their life because they're focused on survival and what's going to happen next, because they're being physically moved along, but also just not provided the time and space to do so. And worried about the negative consequences of having to survive, living in public. But like also happy to send strategies, right? Like we got them. I just don't think there's a good comprehensive plan that's happening.
Yeah, I agree with you that it needs to be pieces of other good plans or other plans. There are good elements there are great elements to things that we're doing here in the city of Boston. And there are things that are happening in other places that we should be looking to replicate and enhance here in the city that could enhance our efforts here. So just, I don't know, Dan or Jessica, if you've got anything to add to that, and places in particular or programs in particular that have some good elements.
I mean, this is going to be more sort of abstract, but I think, we just saw Oregon decriminalize all drugs. I think that's something that really needs to be sort of like thought about, taking away the sort of the criminal element of substance use. We've also seen an increase in the attention being paid to the use of MDMA and psilocybin as adjuncts to psychotherapy. I think we're looking at populations with tremendous amounts of trauma. Boston should be thinking, are these types of medicines that are currently being investigated and approved through the FDA something that we want to be more proactive about, because these are tools that can be used in psychotherapy to address some of the trauma that creates the recidivism that substance abuse is based upon. That trauma is where a lot of this comes from. Realistically, I can't speak to sort of any like established programs, because I think a lot of what we're dealing with is there's a lot of elements of it that are really kind of modern. And as things move slowly, a lot of cities are trying to move along at the same pace. But I do think that those are two avenues that, we should sort of be like paying attention to.
Councillor Desavi George, did you freeze? Are you good? Oh, you're muted.
Now I'm muted. Thank you very much. I don't know if Jessica had anything to add, but I'm all done with this round of questions. Thank you, Mr. Chair.
Thank you. Councillor Baker, the floor is yours.
Thank you. I don't totally disagree with everything that this panel has to say, but I mean, their focus and anti-police that they talk about, I think the solution is in something like what Dan had talked about. It's police paired on with clinical professionals, whether it's nurses or outreach workers. That's where it is, because the reality is a lot of these people down on Mass and Cass, they're not your harmless homeless. They're I mean, with the newer drugs coming, the stimulants coming, it's becoming more and more violent down there. And I would think that the healthcare professionals probably want the police on with them. That's about all I'm going to say there as far as safe injection sites are concerned. I wouldn't be opposed to one going into Somerville, but I would be opposed to one coming down on Mass and Cass or anywhere in my district, because I think my district has enough right now. Kim, to talk about the hotel that we're experiencing right now, that is vanilla compared to what's going on in Vancouver and San Francisco. Imagine 10 of those in one area, just totally people in and out, going crazy, drug.
Councilor Baker, you muted.
San Francisco has not used a heavy policing presence there. They're hands off on all their police, and it hasn't worked for them. They're overrun. The Tenderloin is totally overrun. Kim, back to the Roundhouse Hotel. Go to Vancouver, go to San Francisco, where they do the SROs in these areas. It's a disaster, a total disaster. Picture that without Pine Street being there and all those people left on their own to do whatever it is they want. It's just, I think, although, I don't want to downplay, everybody believes in what they believe in, but I can't get on board with this type of thinking. I think to poo-poo Section 35 when we could use it as a tool, a real tool. I've sectioned multiple people in my life for Section 35. Most of the people that I know that were on heroin, that got off heroin, it was Section 35 or jail that got them off, because if they have the opportunity to go out and continue to use, they're going to continue to use. So not really a question there, but I think we have to be careful having these conversations about safe injection sites. And I mean, the guy Leo earlier said, we have to commandeer private property. What does that mean? Commandeer private property? So he wants to take people's property. The police need to be involved in this solution. The police that are here now are not the police that were breaking down the doors in the 80s to go after crack dealers or whoever they were going after. The police here, the Peter Messinas of the world, they care about what they're doing. And when we take low-level offenders and put them in front of a judge, that's an opportunity for a diversion. So I think we should stop with of course, it's never going to stop because it's in vogue these days. We have to stop with the anti-police, because the police, EMS, and fire have to be at this table. It's a reality. Thank you.
As do substance users.
Yeah.
People in recovery.
Do you really think that you're going to get someone from down in Mass and Cass to sit in on a 4-hour meeting right now?
If I could speak to that, that certainly was our hope to do that. I believe we were going to have that done. And to be clear to folks listening, I think that their piece on this is probably more relevant than mine. Whatever anybody, in my experience as somebody who had clients who were on Mass and Cass, I worked for them. I continue to still have them be people that I work for as an elected official. And so I certainly was trying, as the chair of this committee and in this hearing, to have them represented here. And I will note that part of the issue with that was that 5:30 p.m. was sort of the time when they were being displaced. And so it makes it incredibly difficult to arrange for them to be at a hearing. And so I recognize what Councilor Baker is saying. I clearly, we're all elected. We all represent our constituencies and we have different views. And so with that, I'd like to claim my time here to just ask the questions that I have on this, which are a little bit different. And those questions specifically are, as we're moving forward, and I really care about public comment, so I'm going to make this short. And so, I think the way that we get to this has to involve folks who are closest to the pain. It just has to. And so as we look at where we are right now, and I'm speaking about today, present tense, COVID, the limitations that we have, as folks who are close to the ground on both sides, Ms. Hurd and Mr. Hogan, what are things that you believe we can hone in on right now that would help the most in this moment right now that just isn't being done?
So I think sort of to respond to both you and Councilor Baker, that the major thing we can do like tomorrow, tonight, right now, is to stop sweeping people from encampments and to stop moving people along. You know, I've spoken with many people and know other, you know, on the ground folks and people, public health workers who have said they have spoken with people who being moved around escalates their drug use, especially stimulants, you know, like meth. Because they're trying to stay awake, because they're trying to not have to find a place to be, because they're worried about being moved along, right? And I also just think, like, how do people in general respond to such uncertainty and chaos, right? We react, we don't respond. So behaviors we see of many people are because they are in constant crisis, just constantly being surveilled and constantly just sort of like being in an uncertain situation. They're surviving in public always, and that is especially due during the pandemic, right? Where like sort of both are like programs that are official and provide spaces for people to be have either like shuttered or had to like accommodate people in different ways. Like I know like my program, we've been outside since March 13th, right? So, you know, there's that. And there's also like the public and private places where people go, like coffee shops and libraries that aren't available. So people are entirely outside for the most part. But all that is to say, I think there's action we can take now, right, to help give people some stability, right? Like if there's an established encampment and we're having challenges with it, right? Like if you provided, like just as we do for our homes, like trash service, bathrooms, clean water, like people right now don't have access to clean, potable water. They live in Boston. It feels entirely absurd. And I think we all collectively experience, including the people who live on Mass and Cass, greater safety if we weren't responding and creating that sort of chaos.
Yeah, echoing what Cassie said, I think looking at sort of what are people's basic needs, how do we meet those basic needs? And Cassie, you just outlined some really great ideas. I would say thinking about this is not a problem that can be solved tomorrow, unfortunately. Like this is something that is the result of like decades and decades of suffering, decades and decades of criminalization, all that stuff. It's not going to get cleaned up immediately. I think we need a multi-tiered plan where you say, okay, within the next year, this is what we're going to do. And then within the year after that, this is what we're going to do, with the idea of not solving the problem, but starting to address the basic needs right now. Then with an idea that over time you're building up the infrastructure to get people out of that neighborhood, so that you say to the neighborhoods that, you know, someone had asked about, what about people that say not in my backyard? And it's like, well, it's here. Okay. It's in your backyard right now. And the goal is that within a year, we're going to create enough services. We're going to expand enough residential beds. And whether that's sort of supported housing, I mean, personally, I'm going to advocate again for, we need a much larger residential treatment system than we have right now, because that's really the thing that it's going to help people to maintain abstinence in a structured setting with clinical staff. You're using sort of you know, what we know about recovery, which is to accept the things we cannot change. We can't change the fact that people are homeless and using drugs, but we can make changes in the areas that we can. We can provide them with access to homes. We can provide them with ways to get off drugs. We know how to do that. There's a whole bunch of people that were on this call that worked with individuals who use drugs. And, you know, we need to, I think part of it too is getting more clinicians involved in these meetings, getting more people that have lived experience, getting more people in recovery that are involved in these meetings and actually able to make meaningful decisions. But I do think some of it is sort of biting the bullet and saying, we can't fix this tomorrow. How are we going to get it fixed within a year, within 2 years, within 5 years?
Thank you both so much. We're going to go to public comment at this point, but I just want to thank everybody who has spoken today for their time. If you are in the attendees, and right now there are 24 attendees and 11 hands up. Some folks I see signed up for public comment that are in the attendees section and haven't raised a blue hand. I would ask that you please do. That way I know when I get to you that you're ready to speak. I don't want to unmute you while you're having a private conversation or you're in a different situation. So if you can raise your blue hand, it lets me know that you're there and you're ready to speak. And so we're going to go to public comment in a second. I just want to make sure if any of my colleagues have to go before the end of public comment, then I'd like to let them get a closing statement now. If they'd like to wait until after public comment, then I'll give closing statements at that point.
Councillor Arroyo, I just wanted to, I know I yield my time and I'm going to continue to yield it. I'm just going to advocate if you can let Jada Rackard go first because she is in middle school and should be ready to go to bed. So I'd just like to advocate in terms of order, if there's any way for her to jump up to the front. Is that okay?
Yeah, that's absolutely fine.
Okay, thank you.
Thank you. And so with that, we're going to start our public comment. Folks can say their name, where they're from, and keep their comments to about 2 minutes. If you're a little bit over 2 minutes, I'm not going to mute you. I'm going to let you say what you have to say. And so please, if you haven't raised your blue hand, please do that. And we're going to go ahead now with Jada.
Hi.
Hi. So, good evening. We can hear you, so you can go ahead.
Okay. My name is Jada Rackard. I'm sure most of you on here know me by now. I've spoken at many town hall and community meetings for the past 3 years. Tonight, I'm here to give you an update on how the past 3 years of my life has looked like. Due to the increase on Molina Cass and Mass Ave, I have had to switch schools because it wasn't safe for me to walk to the only school that I've known since kindergarten. I've seen several people overdosing and defecating on the sidewalk. There has been an increase of homeless and drug addicts walking up and down my street. There has been an increase of theft in my neighborhood. I have been approached by many homeless people asking me, a 12-year-old, for help. Imagine that. These are just some of the day-to-day situations I go through. Time and time, I've wondered what's going on and why no one will help them. At 10 years old, I decided if they won't or can't help themselves, then I would. I was always told that there is power in your voice, so I decided that I was and will continue to use my voice. I started with holding a standout and blocking the street in front of my school. I held a meeting with the superintendent and mayor and was promised many things. One was a seat at the table where they would be making plans regarding Mass and Cass, but till now that has never happened. They put a fence around the area and posters up, but what is that supposed to do for the trauma that I deal with on a day-to-day basis? I've taken my voice to Washington, D.C. I have asked the governor for a meeting. I have held protests and I have been ignored. Today, I'm here to ask you for your help. I am traumatized by what I see on a daily. I am concerned for my peers as well. Time after time, children are being taken from their homes due to it not being safe. We are taught in school that we shouldn't use drugs, but we walk outside and we see it's okay to see it happen in front of our house and in front of a police officer. I ask you, who is failing us now? I don't have a solution to this problem, but then again, it's not my job to. I am 12 years old. My job is to go to school, get an education, and become a good person. Your job is to keep me safe. My ask is simple. Please provide adequate care for those in need on Methadone Mile. I also would like to speak on just one more thing, if you don't mind. Tonight, I have waited over 4 hours to voice my concerns about the safety in my community. I am also limited to speak for 2 minutes. I feel like this speaks volumes to how much my life and my community are worth to you. Please do better. In the end, I will learn from you.
Thank you. We're going to go to, I'm going to do it in the order that I see it on the list. So Domingos DeRosa is next. And then just so folks can prepare themselves, Andrew Brand and then Jacob Urena. Domingos, are you unmuted?
Yes, I am. Can you hear
There you
me?
go. Yep, floor is yours.
Can I get my video up?
I actually don't know how to enable that.
Oh, that's not cool. I like to see the audience and the audience to see me. But anyway, my name is Domingos De Rosa. I am a taxpaying citizen, resident here in Boston. I've been dealing with this mass and cast issue for about 8 years now on an ongoing basis to address the issue that we face as a city regarding individuals who are looking for placement and treatment. We feel that as a city, we have neglected this issue for far too long, that it snowballed into this current matter that we are looking to address, causing us to be behind the 8 ball. Tonight, it's a total disappointment to have myself and my community sit well after 9 p.m. to have our voices heard on a matter that we have been vocal and demonstrating on for months, weeks, years. To sit here and listen to different agencies speak on the behalf of us as a city as a whole shows us the lack of attention individuals are giving this matter. We who live here, who have to deal with this 24 hours a day, who have to navigate around this issue so our children can feel safe enough to live in our community, for our elders, for us who shop at South Bay Mall, which is our only source of shopping in the city. Again, I can go on and on about this. I cannot put 8 years of frustration into 2 minutes. I'm going to do my best again, but this is a total disappointment to me as a constituent, as a voting constituent here in Boston, to have us, sit on this meeting that should have been at, 11 o'clock in the morning or 1 o'clock in the afternoon at a reasonable hour, at least to say. It's 9:34 p.m. and there's a handful of folks who continue to text me, who feel disrespected at the fact that we are always put last on issues that affect us the most. I appreciate you for your time. I appreciate you for bringing this hearing to the forefront. I will make a promise to this group and anyone who is listening. We are not going anywhere. We will be given a seat at the table, even by force, if we have to, because this issue seems to be put on individuals who hold titles within organizations instead of folks who are actually dealing with these issues on a constant. All the photos that were shown to us, those are great, those are beautiful. But again, visit our website, visit our webpage, and you would see thousands of videos, hundreds of videos and photos of what we deal with on a day-to-day basis. So I end by saying thank you to my community for sticking with us and for staying on this hearing as long as you have. You guys have a great night and be safe.
Thank you, Domingos. Andrew Brand, you're next, followed by Jacob Urena, followed by Marla Smith. Mr. Brand, if you can unmute.
Okay, can people hear me now?
Yes.
Great. So I want to first thank everyone for their patience, including us residents. I'm going to try to hold it to pretty close to 2 minutes. I could go into a lot more detail on some of the stuff, and please reach out to me if you're interested. So first, I want to thank the mayor for creating the poop cleanup pilot, and so anyway, I'm here to ask you to start decriminalizing harm reduction services decentralizing harm reduction services immediately. For the past 7 years since A-Hope opened, Boston has added more and more harm reduction services into the mass cast area, and only into the mass cast area. This culminated when, after promising no more harm reduction services, they created comfort stations complete with a makeshift sift. In late September, Boston moved these comfort stations 4 blocks. Not coincidentally, the October 311 needle pickup bullseye and likely the public pooping also moved the same 4 blocks after having been stationary for many years. This is more evidence that harm reduction harms neighborhoods. If Boston likes to think of Mass Cass as a place where addicts come to recover, then why are all the services unique to the area, harm reduction services designed to keep addicts comfortable and safe without fear of death or jail? The natural consequence of Boston's permissive attitude has been to traumatize those truly seeking to recover. Poor people seeking treatment at BMC, the only city's free hospital, small businesses, residents, and most importantly, our children who live in the neighborhood. Lately, there's been an increase in stabbings and shooting and other violent crime. If Boston insists it wants to be a mecca for illegal and dangerous drug use for the Northeast, it's time for other neighborhoods to do their share. However, if Boston truly wanted to help the addicts in the neighborhood, it would limit harm reduction service to mobile vans and add comprehensive treatment resources and aggressively coerce the addicts into take advantage of them, as has been successfully done in Portugal. But that's not politically correct, and it runs afoul of the medical community who created the problem in the first place by ignoring their eyes and blaming it on pharmaceutical companies. What I'd like to see from the Mass Cass Task Force is that they set measurable goals, report on them, and not on the effort and money spent trying to alleviate the problem. And thank you.
Thank you, Mr. Brand. Jacob.
All right, thank you.
Thank you.
Yes, can you hear me?
Yep, floor is yours.
All right, awesome. I am Reverend Jacob Barreda, Commissioned Mission in the Order of St. Martin de Porres, and I currently live in Mattapan, but I've had the privilege of growing up in many parts of the city, including Dorchester and neighboring parts of the city of Boston. I'm here today to share a brief testimony because this issue concerning substance abuse disorder and methadone mal has not only affected parts of the city, but many loved ones. I have seen this, which has been a pandemic on its own in the city of Boston, be met with what I can only classify as surface area change, to the detriment of many communities, in specific, many communities of color in Boston. I have seen many come in and time out and state the time needed to address this issue, but it seems that the city hasn't seen the patience wearing thin in our communities. When children find needles near their homes, in their parks, in their schools, how much longer do we believe that it will take for this issue to be addressed in a real substantive way? We as a community have given the city the time to address this issue, and yet it seems to be as us looking at paint drying when it comes to this issue. So I ask again, for those who are asking for more time, how much more time do you need? How many more children will be inflicted by this? How many more communities will have to wait because we don't have time for complacency and inaction? We, the people, have been picking up some of the brunt work of this, for it is our children who live in our neighborhoods, which are constantly under attack and underserved. As a person who has worked in the nonprofit field, focused on homelessness and substance use disorder, I have seen the extreme disparities when it comes to this issue. Staff are few, underpaid, burnt out, programs are underfunded, overcrowded, and offer little to no resource due to the lack of funding and the lack of implementations of solutions offered by those in the communities. And there's also a lack of transparency when it comes to what the funding we do provide produce. And so let me be blunt. I have come in contact with organizations tackling substance use disorder whose work focus on checking specific boxes in order to continue receiving funding instead of creating substantive change in the lives of the members we are servicing. I have seen the disconnect from those working in the fields to those living in the areas impacted. I have seen a disconnect with solutions offered by those who are viewing this from an outside lens and those whose stoops are filled with needles and who themselves suffer from substance use disorder. And so it is ironic to see people who are not in the forefront of this issue offer solutions. And it is ironic for us to commonly believe that the consequences that many of these systems and policies, such as the overdoses after forced detox, are to be ignored for this minuscule margin of success. We need to hear the cries of the community and emulate the sentiment when we say the people closest to the pain should be closest to the power, driving and informing the policymaking. That is a statement by Congresswoman Ayanna Pressley. And so yes, the people suffering from this should be at the table. We want they want to be at the table and will offer solutions necessary to address the issues that found at the table, as long as you accommodate them a seat and a time where they are able to be vocal and raise their voices. As an ordained minister who works within many of these communities, I have come to explain to people that yes, as we are people of faith, we are to pray and uplift our communities, but faith without action is dead. Therefore, we are asking the city to offer the same. While nice words and nice goals are great, we like to see the focus of action when it comes to conducive change in mental health, substance use disorder, and programs like Mass and CAS. We in the community understand that COVID-19 has placed the city in a tough public health emergency, but we need the city and the state to understand that the city and state was inflicted with homelessness, substance use disorder, mental health issues prior to this pandemic, and the response to those specific areas lacked fervent passion we desire to see. It is time for transparency, it is time for action, and it is time for Boston and Massachusetts that quote unquote claim to be progressive cities and states meet these issues with progressive solutions, for what we've been doing has not been working. Thank you for your time.
Thank you. We're now going to have Ms. Smith, Ms. Perea, and Ms. Q. Ms. Smith.
Good evening. I wish I could see eye to eye who I was speaking to at this point. My name is Marla Murphy Smith. My family and I live within the 1 mile radius around Mass and Cass. I live along Methadone Mile, blocks from the shelter on Southampton Street. I grew up in Dorchester in the Adams Corner area. The needles, drug use, and public camping going on in my park, Clifford Park, would not be allowed to occur near the Garvey Park, Toohey Park, Dot Park, or any other park in the city, nor should it be. But these are everyday occurrences in Clifford Park. The situation has reached an unsustainable crisis level. This 1 mile area cannot handle more services for both active users and those seeking recovery. Other parts of the city and the state have to help. Decentralization would provide a much needed release valve. Mayor Walsh has urged people within the mile to be kind, compassionate, and understanding to those he acknowledges are sick. Why, if these people are sick, is so little being done to directly address their sickness? When tuberculosis and polio struck Boston in the early and mid 20th centuries, hospitals had dedicated wards and clinics were built to cope with the crush of patients. We opened emergency field hospitals for COVID. Sick people deserve health care. Sick people deserve treatment beds. There are insane numbers of discarded needles everywhere. To avoid being stabbed, I no longer walk in the park without leather boots. We tell children to never touch a needle, and we stop them from engaging in simple childhood pleasures like kicking leaves. We avoid walking our pets in the park at all. We have sharp bins in front of our schools. Residents, our elders, and most upsetting of all, our children, are seeing things like users injecting drugs in plain sight, public urination, sex acts, violence, including at least 2 homicides. It must be acknowledged that what is harm reduction for one population is unequivocally harm creation for another. Active drug users are people in crisis, and more than anyone else, we want them to get the help and treatment they need, but not at the expense of our own community. We need this area to be designated a public health emergency, and we need to receive equitable treatment with other neighborhoods in Boston where this absolutely inhumane negligence would not be permitted. The trauma to residents is as real and as valid as the trauma to users. I would like a place at the table, and I'll bring my own damn chair. Thank you.
Thank you, Ms. Smith. Ms. Perea.
Good evening. Can you hear me?
Yes.
Okay, great. So thank you. I am the sister of a person who was out on Mass and Cass for quite a few years. His life consisted of begging for money, picking food out of trash cans, and of course, being an active user. My brother came from a good home, but unfortunately was put on prescription pain pills at a young age. It later spiraled from there to heroin use. He absolutely has a family who tried to get him help. Time and time again, he overdosed and was brought back. I'm here to tell you, these people have families who love them. They deserve a chance to be sober. This is how my brother got sober. One night, while trying to score his next fix, my brother fell off a balcony. The fall caused a brain bleed. Today, yes, he's sober because luckily it was a nurse who found him dying on the sidewalk, and the staff of BMC Hospital were able to save his life. But it was at a great cost. He is only in his 30s and is not able to live on his own because of seizures and many other challenges that come from having a traumatic brain injury. This one night could have been avoided if methadone mile was about treatment and not enabling. Please, I beg you, stop taking our loved ones and subjecting them to use and to leave their families. How do you expect us, the family members, to help them if you are just giving them a place to get high with no treatment? The methadone mile lifestyle almost killed my brother. There are more families of people in those streets, just like my brother, who want them home. Yes, my family is lucky, but then again, you don't know the pain and struggle that came after him getting out of the hospital, so it's easy for you to assume that. Methadone mile stole my brother, my real brother. He didn't even remember using after his accident till much later. That's how he got sober, and it was traumatizing. You have the power to bring people home to their family. Please, before someone else loses their family, friend, and loved one. My name is Shannon, and I'm a recovering addict, 15 years sober. And even though heroin was not my drug of choice, I know what it takes to get sober. Your comfort stations are not that. I know what recovery looks like. Methadone mile isn't it. The fact our great city of Boston has a place dubbed Methadone Mile is an embarrassment to us all. I'm calling on you to clean up our city, put programs in place to give loved ones a chance at sobriety and life. Stop being that so-called friend that every mother's worst nightmare who introduced their baby to what the high life is all about. And in closing, this is for all the people who were lost but still loved. Thank you.
Thank you, Ms. Pereira, and I'm sorry for your loss, and I wish you continued success in your recovery. Ms. Q, followed by BJ, followed by Isabel DePina, followed by Jada. Ms. Q, you have the floor if you're unmuted. You're unmuted, Ms. Q, if you can just, if you're able to speak. All right, we'll come back to you while you figure that out, but we'll come back to you. We're just gonna put you lower in the line. BJ, if you can unmute.
Am I muted?
Nope, you're good.
Okay, I apologize. I have a very bad cold, but I was not going to speak tonight for a number of reasons. But I'm very disappointed in the fact that we just lumped this all into one meeting, and we've been on this Zoom now for what, 5 hours? It's very disappointing to me, but you know, my name is Brenda James. I am from Mattapan. I watched gentrification. I watched the war on crime. I watched drugs become rampant in our communities. I watched Black and brown people being targeted. But my most important role, sir, is that of a former Boston police officer. And I served the city of Boston for almost 20 years. The city has failed me greatly. I did quite a bit of work for the city. I was a community police officer. I was a juvenile officer. I did work with the mentally ill. I did multidisciplinary teams. So I do agree that it needs to be that type of an approach. I think what's disappointing me is I'm hearing too much dialogue about Section 35. That puts the pendulum back in this whole war on crimes and an approach that will be traumatizing and criminalizing people that are very vulnerable. I've always known this problem was rampant, that it was becoming a huge epidemic. I think it's really, really concerning to know that the city is not responding differently, knowing that children's health are at risk. Not just individuals and families, that's bad within itself, but children who can't play on playgrounds, they are at risk for being pricked with needles. This is very, very serious. And I'm disgusted that it has gone on as long as it has, and that we're now talking about the gang unit or the drug unit. I personally know what that means. And so because I feel so strongly about children and families and stabilization and the work that I did in this city, that I have accolades for and that I was serious about, I want to go on record saying that we need to fix this problem. We need to fix it, and it is an urgent need to fix this problem right away. And criminalizing people and locking them up is not the answer. You can definitely, I think, I want to say this before my 2 minutes is probably up, I don't know. But as a community police officer, I took specific training to be involved with specific groups. And I do think that you should have police presence. I believe in that. But it needs to be more of a community policing model as it was in the 90s when I started. I started in 1994. I was pushed off the job in 2015. That's another issue. However, I believe in this community. I believe in the city of Boston, and we can't keep saying Boston is strong. It's a public health crisis. The people closest to the pain should be at the table, and it's not happening. So I would love to see some solidarity, some multidisciplinary teams, and some people give credit where credit is due. You have grassroots people out there really, really spending a lot of time. They're very passionate about this, but it's time for people to give back to the community and show that we're serious. I mean, we're at a time right now where the nation is outcrying for social justice and criminal justice reform. This has to be taken a little bit more serious. I thank everyone's time.
Thank you, Ms. James. Ms. Q, followed by Isabel DePina, followed by Jada, followed by Amanda Govan. Ms. Q, did we solve the volume issue? Can you hear us? Okay. Ms. DePina.
Hello, how you doing?
Hi, how are you?
My name is Isabel. I'm from Randolph, but I lived in Boston since I was 5, and I'm 38. So I am a conflict resolution and May I UMass Boston, and I like this system is injustice. And I was going to read my letter, but I sent it to you guys. So what you guys need to know is acknowledge the people of your town, you know, and accept us and help us with support and let us heal. So with that being said, while I was listening to you guys didn't give the public the thank you, Juliana. You did, you saw us and you want us to hear us, right? So thank you for that, you know, to recognize us, because we are the people that's fighting for your people. We doing your job. You need to do your job as public officials. So with that being said, I was also in class from 5:30 to 8:15, just listening to see if you guys would give us a time to talk. And it took this long. So I'm very disappointed. And this is the reason why I'm a labor study and a conflict resolution, okay, MBA. I'm coming for everybody. And if I have to take your job, I will.
Thank you, Ms. Pereira. Jada, followed by Amanda Govan, followed by Yahaira Lopez. Jada, the floor is yours. Jada, are you there?
Can you hear me?
Yep, there you go. Floor is yours.
Okay, thank you so much for the meeting. As I echo the people who have spoken, yes, this is a disappointment. I've been with the Human Services for over 10 years, and just a matter of what I see on methadone mile, I'm literally right in the middle of it. I've been in the middle of it for over 4.5 years, and it's just no change. I feel that right now, you know, the people are actually coming in my backyard. They're right in front of my building, you know, while we're fighting gentrification over 100% rent increase, we're fighting that matter alone, let alone the issue of the opiate crisis, the methadone. It's a war in the middle of South End where I am. I know there's not a lot of people who spoke up from different agencies who actually live in this area to know what it's really like and what the severity of it is. I've witnessed people who have been overdosing in the middle of the intersection. I've seen people in wheelchairs fall over, needles falling over. I've seen them build their own places and beside the walls of the buildings, on the doorsteps, by the trash cans. We see it every day. And it's nothing that's changing. If we're voting for people to speak up for us and putting every official in this seat to do what they're supposed to do, we expect that to be done. We are voters. We have a right to be heard. We have a right to know that you or whomever is supposed to be in seat to be accountable. Yes, we need you guys to be accountable. Yes, we need more transparency. Yes, we do need you to stick up for us because we voted you in. So this is your time to show us, what can you do for us? We cannot keep putting you in the seat every year, every day, every time we're having the same issue. Don't come knocking on our doors looking for votes if we can't knock on your door and let you know this issue is going on for a long time. If you can't handle reality, you should not be in this seat. Thank you.
Thank you. Amanda Govan. There you
Hello,
go.
can you hear me?
Yep, floor is yours.
Hi, my name is Amanda Govan, not Govan.
Sorry about that.
That's okay. A lot of people just screw my name all the time. It's nothing. I would like to come forward and say that I was raised in the crack cocaine era. Me and my mom was living on Worcester Street, and it was mainly me and her. And my mom has been using since she was a young girl because she wasn't raised right and in the proper parenting condition that she needed to be in. My mom has been sober for 30 years. My father has been sober for 15 years from heroin. For me to live in the South End, Atlantic Street, and for me to have 2 daughters, and for to have people on the outside looking in still feel like they can still discuss and perpetuate a lot of these solutions and don't necessarily care about the children that are literally in the throes of the traumatic cycle that is still keep on going, that y'all are still making financial gains off of the backs of us. It is not fair. It is not fair. It is not right. At the end of the day, I'm a mother first. I have 2 young daughters. I have to stop people from getting high in Ramsey Park. That picture that y'all showed was beautiful. The morning sunrise and all of that. But you don't see the needles that are purposely being left behind. You don't see the people that are intentionally sitting on the bench, knowing that this area is for children and they just want a place to shoot up. You don't walk through my part of Atlantic Street where addicts with their book bags, they're just looking for a building where there's a door open, where there's a stairwell where they can sit and shoot up because they can't deal with life. At the end of the day, this is a public health issue, but I am tired of people asking the brown and black community to have compassion, to have some sort of civil restraint when that passion was not shown to us in the 70s, 80s, 90s, and even the early 2000s. At this point in the game, if y'all don't act fast and if y'all don't act highly in regards to humanizing this issue and give the people what they need and protect the children first and foremost, y'all will be facing a lawsuit for community neglect and public safety neglect because this is not fair. I shouldn't have to walk to Dunkin' Donuts and see addicts on Mass Ave getting high. When I think of my mother that struggled to raise me and my brother by herself in Section 8 housing in Framingham because she was shuttled out. At the end of the day, humanize the issue, protect the children, get the help for people that want help, and for folks that are coming from different communities to squeeze blood out of the stone of Boston financials that we really don't have right now, put them back in the communities from where they came from and make sure that that community knows that this is your resident, this is your issue. We can't take on your problem if you're not contributing to our solution.
Thank you, Amanda. Haida Lopez, followed by Sarah Henderson, followed by Joshua Pierce.
Can you guys hear me?
Yes, Yahida, the floor is yours.
Good evening, guys. My name is Jahida Lopez. I am the daughter of Maria, the sister of Daisa, the sister of David, the aunt of Jacity, Jadrian, Cito, and now a newborn to the family, all who still are living in the same location that I grew up for over 30 years. My family has been in the South End and Roxbury in the same apartment and in the same community for 30 years. And since I was a teenager, I have been seeing the plot to take over the South End for lobbyists and those that capitalize off of people's pain and suffering, and most importantly, the Black and Brown community. And I want to start by saying, for those that are sitting on this seat that continue to speak up for my community, my Black, Brown, and Latino community who don't know anything about my community, I'm gonna need you to take a few steps back and go back to your communities and start advocating for safe injection sites in your communities and see how your communities appreciate this level of advocacy in your community. And two, let's be clear that all the things that are happening on methadone mile have been done due to lack of accountability and lobbyists again and nonprofits again who continue to capitalize off of people's pain and suffering while executive directors are making over $200,000 a year. Meanwhile, you have over 1,100 to 1,200 individuals that are on methadone mile that can't even get into an apartment. And the mere fact that we have an individual here promoting and saying that housing is a low threshold to seeking individuals to really seek treatment and recovery, you should be ashamed of yourself. Because I don't see anyone who can really get treatment and recovery if they can't even find a place to sleep and take a shower. Meanwhile, you're sitting here and you're advocating for someone's death, because that's what you guys are doing. You guys are advocating for people to inject themselves with an illegal substance. These individuals are somebody's brothers, they're somebody's sisters, they're somebody's children, they're somebody's grandchildren, and most certainly somebody's parents. You should be ashamed of yourself that you think that allowing an individual the key path of their demise is considered treatment and recovery. And I'm going to ask you, so in the same breath that you're advocating for harm reduction, consider my family and the creation that you're creating in my community and the plot that you guys have had for over 30 years in trying to take over the South End and Roxbury for your capital gain. And with that being said, please don't come in my community advocating for something that you have nothing to know about when you're going back to your communities and you have no clue what it is to live in a marginalized and disenfranchised community. So don't speak about my Black and Brown people when you know nothing about that. And good night.
And just to touch on that last piece about the low threshold, to be clear, low threshold means making homes easier to get, lowering the barriers, not that it's a low priority. Low threshold housing is housing that has less barriers to entry. High threshold means that they require more conditions to give that housing to those folks. Sarah Henderson, Joshua Pierce, Anissa Buchanan.
Good evening. Can everyone hear me?
Yes, Ms. Henderson, floor is yours.
Thank you. My name's Sarah Henderson. I'm a lifelong Boston resident, originally from Dorchester, now currently residing in Rosendale. I'm also a clinical social worker and a parent of a 10-year-old. I've spent many months listening into conversations and concerns of residents who live in the immediate and surrounding vicinities of Mass and Cass. I specifically, excuse me, want to amplify the voices of the South End Roxbury Community Partnership, who are on the front lines navigating these realities every day. What I have heard repeatedly is both compassion for those struggling with homelessness and addiction, and also the psychological stress of enduring the daily sighting of people injecting themselves, discarded needles, blatant sexual activity, and interpersonal violence. As a parent and a clinical social worker, I'm extremely concerned about the impact on children. Children who are exposed to this trauma, addiction, and inhumanity daily. Adverse childhood experiences, of which exposure to violence and addiction qualify, can change brain development and are linked clearly to chronic health problems and mental health and substance misuse later in life. If you've been to the area of MassCast recently and have seen what's happening, imagine your child needing to maneuver all of that. Then imagine your child asking the tough questions. Why is this happening? Why isn't anyone helping? Why can't I go to the park to play? I also worry about the enduring stress on parents, many of whom must sweep walkways and parks daily to ensure a safe place for children to play. How do we explain to our children why in a city as resource-rich as Boston, there are people bleeding, defecating, overdosing, and dying on streets and in parks? There's an urgency as we approach the winter and are navigating ongoing concerns related to COVID. We cannot wait for construction on Shattuck campus to begin or the Long Island Bridge to be built. We must do something now. And the responsibility of acting must be all of ours throughout the city and not just the residents of Dorchester, the South End, and Roxbury. The work on the part of the city must start with transparency, particularly around data collection and sharing. The task force itself should be reaching out to residents whose voices have not been represented at the table. Many of those are here tonight. We need to work urgently to decentralize harm reduction services. There needs to be increased outreach efforts aimed at getting people voluntarily into treatment, and more importantly, stable housing, more residential treatment opportunities, relapse prevention resources, and a substantial increase in outreach staff. These efforts will involve collaboration on the part of the city and state and various private and public agencies. This will require strong and ongoing advocacy by our elected officials to ensure it happens. We will most certainly remember who acted and those who just offered condolences. Thank you very much.
Thank you, Ms. Henderson. Mr. Pierce.
Hi, can you hear me?
Yes. What is yours?
Hi, my name's Josh Pierce. I'm a resident of Worcester Square, along with my wife and 2 young daughters. I'd like to talk about a couple of issues that I don't think are often addressed or barely addressed with respect to MassCast. The first is the traffic situation. We're taking what is already one of the most vulnerable populations in our society and directing them to gravitate towards the intersection of a major thoroughfare and a major highway at Mass Ave and 93. Individuals who are incapacitated are provided with clean needles and sent off into oncoming traffic, which is unconscionable. The second is that the use of speedballs or goofballs, and I'll acknowledge that some people have brought this up on the call, but essentially it's heroin and meth mixed together, is on the rise near MassCast based on what I hear from health professionals at BMC. The neighborhood relationship is about to get 10 times worse if meth continues to be added to the equation, where a once relatively docile opioid addicted population starts to get much more aggressive in a neighborhood filled with kids. On that note, the city is doing next to nothing to improve safety at the schools in the immediate vicinity of the opioid capital of New England. If I were a public official, that would keep me awake at night more than anything else about this crisis. Used needles are routinely found all around the Orchard Gardens and Hurley schools. This isn't Dallas, but it's also not Amsterdam or Vancouver. Needle exchanges don't fly in a place like Dallas because the population won't support it. Needle exchanges work in Amsterdam and Vancouver because the largely progressive population supports it and the state and local government is all in. Here in Boston, we have a progressive population that supports these programs, but a government that is unable to manage them. I tried to drop off a used needle the other day at the South End police station, and they couldn't even tell me where the sharps box was. This would never happen in Amsterdam because their governmental organizations provide the resources necessary to address this problem, and the responsibility is shared by everyone in their communities. Until we have a greater commitment on the state level, no one should be holding their breath for an addiction services clinic to open in Wellesley. We're dumping this problem in one corner of one city and hoping for the best, regardless of the impact on the addicted population and the surrounding neighborhood. Lastly, I think we often focus solely on the impact of all this on either neighborhood residents or the homeless and addicted population. I want to start by echoing what several city councilors mentioned about the appreciation we all need to have for the police officers, EMTs, and recovery services teams who work in the MassCast area. The burden that we're putting on these frontline workers is not sustainable, and they're taking the brunt of the wrath from residents when they're just trying to do their jobs. Jennifer Tracy and the Office of Recovery Services are doing God's work, and it's unfortunate that they often receive the wrath of neighborhood residents. The governor and the mayor's office need to be shouting this from the rooftops and going to bat for the frontline workers every day, because the jobs we're asking these people to do are insane. 911 wasn't meant to be used to report defecating in an alley. Thank you.
Thank you. Ms. Buchanan.
Hi there, my name is Anissa Buchanan, and I'm a resident of the South End. So even though MassCast is considered to be the hotbed for these issues, it has spilled further into Boston, including the South End, Southwest corridor that includes Titus Sparrow Park, as well as Back Bay Station, Fenway, and of course, Lower Roxbury. Needles, tourniquets, human feces can be found around the neighborhood, next to playgrounds, dog parks, as well as next to the local businesses that are struggling to stay afloat due to COVID-19. Individuals are being attracted to the city, can now be seen rifling through trash bags, stealing packages, and acting erratically toward innocent citizens and breaking into cars and patios. We have found ourselves confronted with a massive public health and public safety issue. The city and state have done nothing to curb the true impacts of methadone mile. It can be argued that the city has inadvertently exacerbated the effects of MassCast due to their negligence and inability to implement sustainable solutions. The city has created comfort stations that have only attracted more and more bad actors to the neighborhoods. These bad actors prey on the vulnerable individuals that call methadone mile or the roundhouse in their home. Why would you, the city, and Pine Street Inn place a separate vulnerable population in the middle of an open air drug market? These comfort stations have done more harm than good to not only the individuals they claim to serve, but to the neighboring communities as well. The comfort stations have essentially become illegal safe consumption sites, and yet the city continues to peddle the false narrative that methadone mile should be referred to as recovery mile. How are these individuals supposed to seek treatment and actual recovery when they're subjected to sitting in a tent in the middle of an open air drug market? This is the equivalent of scheduling an AA meeting in the middle of a bar. A video is circulating around social media showcasing how outreach workers are allowing individuals to use narcotics in these tents. As an outreach worker or city employee states, this is more relaxing. You can use and do your thing. The police won't bother you here. While we continue to hear talks about opening a sanctioned safe consumption site within Boston proper, ask yourselves this: will it actually work? There's already a de facto site as of right now by the Southampton shelter, and it's only made the situation worse. That's all.
Thank you, Anissa Buchanan. Mr. Justice or Will Justice, followed by Jeff Durham, followed by Ryan Fisher. And if anybody else hasn't been heard yet, if you can raise your hand so that we can get to you too. Mr. Justice.
All right, can you hear me now?
Yes.
All right, then. So this is Will Justice.
Mr. Justice, you got muted. Can you unmute?
All right, so can you hear me now?
Yeah, and we're gonna restart it, so don't worry about that. You can go ahead, take your time.
All right, so I've been part of a lot of movements within the city, trying to do things in order to, like, project the voices of the people in the city. I'm from Roxbury. I'm with Reclaim Roxbury, among other things. I'm with the South Boston, you know, Roxbury Collaborative, and I'm just saying, like, a lot of these people who are from the neighborhood aren't as sympathetic as people should be when it comes down to it, because we are dealing with our children having to deal with dodging needles in the park. And I mean, a little while ago, I had an 8-year-old come over and tell me that there is a needle where the little toddlers play inside Ramsey Park. And I called 311 and didn't find out that 311 doesn't answer after 6 o'clock. So I sat there for like 2 or 3 hours before I found out that they don't even come out after 6 p.m. So that needs to be like a 24-hour thing. And the very next day, there was another dirty needle with blood that you could see inside of it in the same park, but over where the bigger kids play. So, and this is an everyday thing. It's an everyday occurrence. And we're having a lot of people that are becoming more and more frustrated. We're watching people walk down the street and stop walking and duck and dodge and, having a grand old time, but it doesn't look good from the outside. So when we have the little ones ask us the questions of what's going on and why is this happening and what's wrong with them, and we have to answer these questions, I just have to ask the question, like, these people are not from our community, and we see that clearly. And the only reason why it is a priority for them to, like, be we have to be patient with them and compassion and all this other stuff, but it wasn't no compassion when it was us out here. When we were out here and they were just locking us up, you could be coming home from school and we had the police just grabbing us up, asking us what's in our bags, and it has nothing to do with anything out here in the streets. It has everything to do with us coming home from school. I mean, I've been punched in the genitals by Boston police because they say that I'm in a high traffic area or what have you. I mean, and these gang task force are gangsters themselves. And when it comes down to it, it's like now we are supposed to have all this compassion for people because they don't look like us and they look more like the people who have been terrorizing us this entire time. And we're being further subjected to more terrorism because of our children are asking us these questions like, what is going on? What's wrong with them? Why are they doing that? I mean, what, like, the little ones are asking, okay, there's a needle in the tree. How did it get there? Is the tree sick? When someone asks me that, I'm like, listen, how do you answer a little one ask you if a tree is sick because it has a needle stuck in it? I mean, it's like, I want to know, we have people trying to subject people who look like me to all kinds of, problems because I may look like I'm up to some trouble, but you see somebody that's definitely up to some trouble, and it's like, oh, well, leave them alone. That let them get some help. And it's like the only help we was getting was shiny handcuffs. All right, so that was not how it was dealt with when it was us. I'm not saying that it should happen for these people, but at the same time, it's like it's kind of hard to find that place where you can be sympathetic to someone who is like, saying they've been given everything on a platter. It seems like they can even be high out in public and nothing is going to happen to them. And there's a lot of frustration, and there's going to be a lot more because of proximity. There's going to be a lot more conflicts. There's going to be a lot more issues. And then we want to protect our children. We don't want to have this in front of them. And when these conflicts start to come to a head, it's going to make us look like the bad guys when we do what we feel is necessary in order to protect our children, because we're not going to wait for 911. I watched in front of a business, we watched two grown men beat up on a girl, and it's like we know that they're addled, and we're looking at this and we're like, someone called 911 and they never showed up. So it's like, come on now. Yet I watched one of my friends get pulled over last night for driving while black, and snatched out of a car. And it's like, and we're still dealing with this. So it's obvious that, you know what I'm saying, it's a racial line that's happening, and people don't want to call it what it is, but I'm going to call it exactly what it is. You know what I'm saying? You don't have the police out here that look like me policing me, but the people that look like the people who are causing a lot of these problems are being sympathetic towards those people because they look like them. And it is what it is. You know what I'm saying? So we're not going to have a nice resolution to a lot of this stuff. I had somebody try to steal from me because they're addled and they felt like they could try to take something
Justice,
from
I
me.
just want to let you know you got a 30-second.
All right. All right. Well, the thing is, they're going to have a lot more conflicts, and they're gonna try to make us look like the bad guys for defending what is ours. And real deal is like we're already dealing with gentrification. How much more are we supposed to take and just sit back and do nothing about? Because it's not gonna happen.
Thank you, Mr. Justice. Jeff Durham.
Hello, can you hear me?
Yes, floor is yours.
Okay, thank you, Chairperson Arroyo, for hosting this hearing and sticking it out until this 10:30 at nighttime here. And thank you everyone else who is listening in. My name's Jeff Durham. I'm a lifelong resident of the city of Boston. I'm 45 years of age. My primary care physician is Dr. Jason Wister of 25 years at Boston Medical Center. I'm a father of 3 children, 2 in college and 1 in high school. All of them born at Boston Medical Hospital. Growing up, I recognized the place as Boston City Hospital. Some of us who are a part of this hearing may share these same sentiments that I'm about to say, but Boston is our home. We were born here. We went to school here. Some of us work here, raise our family here. And there are some of us will have our sunset here. But it bothers me when I have to walk by Mass Ave to go to see my doctor. It bothers my children as well, as they have to walk by needles. I've joined the South End Community Partnership within the past couple of months. We've held these Facebook one-on-ones with elected officials. State Representative John Santiago said we need to do more. We'd love to see if there's more practitioners on the task force. Anicia Sabi George, her work with what she's doing in healthcare. Having to listen in to Boston homelessness that focuses on the healthcare for homelessness and finding out, well, they take in 11,000 people a year, but 4,000 of those people are suffering from an opioid issue. Hearing the Suffolk House of Corrections over there in South Bay, you're 140% likely to end up on methadone mile. And yes, die on methadone mile. Those are just facts. Those are just what was discovered off of these short, candid conversations within a 3-month period of time to where we're at today. Councilor Mejia, focusing on the Dollar Trail. I'm still asking for the Dollar Trail. I've not gotten that from this hearing today. We asked the city of Boston about the Dollar Trail. If they wanted to bring in federal dollars, state dollars, we want accountability. We elect you into office to represent the voices of the voiceless. And it took us 4.5 hours into this hearing to be heard. I'm asking for more. I think this is a step to getting there. I would love to be part of the 3.0 plan. And finally, to the task force, there are people out here that want to be involved. And I did not get that from this conversation tonight. My neighborhood here in Carmen Square, we're okay. We have our issues. But my home is Boston. I just want to be a part of the puzzle, be a part of the piece of the puzzle to fit in. Thank you all for listening. Have a good night.
Thank you, Mr. Durham. Mr. Fisher.
Can you hear me?
Yes.
It's Miss Fisher.
Miss
I'm
Fisher,
Ryan. I'm a
sorry.
girl. No, don't worry. It's a family name. I've written a statement, and I know we have 2 minutes, and it's my first hearing, and I've heard people read their statements, and sometimes the emotion is lost when you read words, but this statement was written with a lot of emotions over a couple of days, so I hope that is not lost on the city council members. And I will say for the panel members, the reason I'm involved, I think I understand Mass and Cass from many points of view. I lost my fiance to addiction. I have family members that have recovered from addiction. I was a kid in the 80s who grew up in a not great neighborhood with needles in my playground. I know even to this day, as a 40-year-old female in the South End, when you see a needle, how that triggers you and what that means to you. So for everyone, city council, the experts from Boston Healthcare for the Homeless, Cassie, I think it was Dave, I just wanted to provide that context from my statement and what I'm about to say. So I think to this date, the conversation, effort, and funding on Mass Cass has typically focused on addiction, harm reduction, recovery services. While this is obviously a critical focus, there is little focus on the impact that Mass and Cass has on the children who grow up nearby. And I think we've heard that from many people tonight, and I just want to echo some of their sentiments. And I have a few examples of what I've seen. And again, I'm a renter. I don't have any, ties to property values. I'm single. I don't have kids, but I just really care about the people that I live around. And I want this South End community and Roxbury, the whole just community in general, to be my home forever. So what I've seen in the street, or my alley where I live, is, there's a preschool class. I think it's a Head Start program. And they walk by my little alley every day. There's like 5 or 6 of them on a little rope with their hooks or the little rings. And they walk in the alley because you can't walk on Shama or Tremont, Washington, because there's too many needles in the morning. And they know what the color orange means, because they'll say orange, 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 and they point to needle caps, because if you live around here, you see the orange needle caps. There's a 2-year-old that lives on the street from me, and he just knows the word Narcan. My nephew is 2 in California. He can hardly speak, and he has no idea what Narcan is. But the 2-year-old that lives 2 blocks away from me, he knows what that is, because he's seen the revival that happens weekly, every 2 weeks, and on a stoop. There's 4-year-olds around me that don't want to play in sandboxes because they're scared, and they know wood chip playgrounds are no-go zones. So if you're going to play in a playground but has wood chips, you just don't play, go back inside. My 5-year-old neighbor has nightmares about going to kindergarten because she's going to be pricked. I have a 6-year-old neighbor. He lost his father to addiction. He was in recovery. They are not from Boston. They moved here within 18 months of moving to the Mass Cass area. The father fell back after being sober for 15 years, and he's dead. So that 6-year-old no longer has a father. There's an 8-year-old that I know, maybe it's my niece, who has seen some sexual acts 2 or 3 times as we drive from Target, to BMC. And she keeps asking, why is that woman doing that to that man? And to an 8-year-old, how do you kind of respond to that? And when an 8-year-old who's really observant sees that more than once, what do you say? Like, you can't normalize sexual activity, especially to a 8-year-old girl. What are we creating here? There's a 9-year-old who refuses to let her parents enter 93 on the Mass Cass interchange because there's hostile individuals. I don't know the proper PC term, those suffering from addiction, but she calls them, the 9-year-old, I'll just use her words, the zombie who tries to keep opening her car door and swearing at her at 10 in the morning. And then multiple times, and people are afraid to say things, but multiple times there's entire school dismissals that are put on hold because either someone is shooting up or getting Narcan while the buses come. Whether it's, and again, I'm not going to say the name of the school, but pick one out of the mile radius around Mass and Cass. It's really disappointing when we hear that there's the quality of life issue for residents. This isn't about quality of life. It's about childhood trauma, specifically created by Mass and Cass. We heard experts tonight talk about past experiences, root addiction causes, but we're actually creating those for the next generation of kids. And this is not okay. Unfortunately, the data on Mass and Cass, the population is, unfortunately, the data on the Mass Cass population is scarce. But one reasonable figure, and I've been out there for about 3 weeks now, is that there is about 300 people actively using and not seeking treatment. By comparison, there are 1,100 children nearby. If you think about the Orchard Gardens and Mason School populations. This number of 1,100 kids only increases when toddlers and other area children are included. Based on the volume alone, why aren't we prioritizing the children and their associated Mass Cass trauma? How can the Mass Cass Task Force decision-making and funding center on childhood trauma impact, both given the relative volume of the population, 300 versus 1,100, and 1,100 is very conservative, and take volume out of the equation. If we think about the long-term impact of this type of trauma on children, developmental, educational, risk of future opioid use, why aren't we prioritizing our kids? Thank you.
Thank you. Of course, I muted myself at the end of this. That concludes our public comment. At this time, I'm going to allow for closing statements for our counselors here. President Janey, Councilor Mejia, Councilor Sabi George, and Councilor Baker. If you have any closing statements, I'm going to go in the order I just said. So President Janey.
Thank you so much, Chair Arroyo. I really appreciate you chairing this discussion into the late hours here, and many thanks to my colleagues, all who were able to join, and certainly those who are still on the call. Many thanks again to the panelists and all those in the public who waited so patiently to testify and to share their stories. And their suggestions on how to move this forward, as well as their many, many, many frustrations about this issue. I'm left thinking, one, there's obviously a lot more work to do in this front, a lot more in terms of the coordination. There is certainly a lot more to do in terms of how we engage people. I'm not just talking about the engagement of those individuals with substance use disorder, but how we engage others in this work. We heard a lot from folks who want to be involved with the task force. But really, I think the thing that I'm left with, and I hope we're all left with, is just the need for more urgency on this issue. And in particular, I'm thinking about how the city was able to respond to the crisis proactively in terms of COVID. And I think we kind of need that kind of urgency with this issue. And so I think we need an approach that is really going to look at this when we're talking about this being a public health crisis. And when we think about this in the context of everything else that is going on, I think that the trauma is compounding. And so I'd like to see us approach this more with an urgency, the way folks have approached COVID-19. Again, the hour is long. Thank you, Mr. Chair, and thank you to my colleagues. Really important that we continue the conversation and follow the conversation up with concrete action. So thank you.
Thank you, President Janey. Councilor Mejia.
Yes, Thank you, Councilor Arroyo, for chairing this, and to Council President Janey for bringing this to the forefront. And I also would like to thank the advocates, the administration, and the panelists who spoke, and more importantly, really thanking the public for waiting as long as they did to be heard. Last week, we hosted a hearing on public hearings where we talked about the importance of really leading with folks who are living the realities. And I'm really thinking that the more that I participate in hearings like this, the more I'm curious to how we can create space for voices to be heard, and more importantly, for the administration and those who are in positions of power to really have an opportunity to hear directly from the people, so that they are also hearing and answering the questions that people have that we may not have answers to. And so I think this presents itself as an opportunity for us to really think differently about how we engage folks in their own lives. I think that for me, as a first-term counselor, walking into this conversation, having been on the outside, screaming, hooting and hollering alongside many advocates, and I know Councilor Janey, you are one of those too. You've been out here in these streets, hooting and hollering about a number of different issues. And I feel like we've gotten to a point where we can't continue to hoot and holler anymore. Now we have an opportunity to really move with a sense of urgency and really listen. And then when I decided to yield my time so that we can hear from the public, I'm taking that privilege of utilizing this little bit of time that I have to go on my little soapbox. But I do think it's important for us to know that there were still a lot of questions that have gone unanswered. The dollar trail, follow that money, still needs to be unpacked. And we can no longer continue to point fingers in so many different directions without recognizing the role that we play and continuing to push the conversation along. And so I think that the sense of urgency that we're all looking for, I think about the work with the fireworks. When that situation happens in May and June, we came out and we hosted community conversations. We got the mayor to host a task force. We created videos. We created opportunities for the Department of Neighborhood Services to get engaged. It was an all hands on deck to address the issues of fireworks. And I think that if we take that model in terms of community engagement, and we're utilizing our resources and seeing that this is a citywide issue, then we may be able to move the needle a little bit further. But what we're doing is we're relying on the usual suspects to be at the table, and we're relying on the usual suspects to speak on behalf of the people. And I think that now, more so than ever, the public is asking us to think and reconsider how we do business here in the city of Boston. And I think we have an opportunity to do just that. So for those advocates who are every day outside cleaning needles and passing out food and doing the work without getting compensated, to the advocates who waited 4.5 hours to be heard, to the people who feel like their concerns continue to fall on deaf ears, to the people who are completely frustrated and about to give up in the system, I ask you to give us one more chance and to not lose hope, because they will continue to ignore us if we allow ourselves to be defeated. So I'm speaking as an activist and as a city councilor, because I'm not going to leave myself at the door to make anyone feel comfortable. And so if that means holding myself and my colleagues accountable to what the work needs to look like, then I'm willing to do just that. So here we go. Let's make it happen.
Thank you, Councilor Mejia. Councilor Asabi George.
Thank you very much, Mr. Chair, and thanks to Council President Janey for hosting or calling for this hearing today. as someone who has been doing this work for the last 4.5, almost 5 years, who has found herself sort of in the trenches and focused on the crisis that we face in our city when it comes to substance use disorders, when it comes to mental health issues, when it comes to homelessness. This hearing today, I think, has brought a few new voices to the table, and I'm encouraged by that. I'm encouraged by the ever-growing circle of interest in this area, in both this geographical area and this philosophical area, and this sort of space in this conversation, because it's so important that we continue to do this work, that we continue to do this work in partnership with each other, that we continue to collaborate on the pieces that are working and find new ways to do the things that aren't. And I think through this evening's conversation, we've talked a lot about some of the outreach that has been successful. We've identified some of the concerns around potential safe consumption sites in and around the city of Boston. We've understood, I think, some of the impacts of the epidemic on the epidemic, or the pandemic on the epidemic of addiction and the crisis of addiction, the crisis of those that are experiencing homelessness and inadequate access to mental health services. So there, obviously continues to be more work to do, and through these hearings and through these public discussions, both the formal hearings of the council and any community meeting in which I participate in, both large scale and small scale, it helps underline and emphasize the work that remains undone. So feeling, although a little tired at the hour, energized at the sort of the road to the work that's left undone. So before I ramble on anymore, I just thank you, Mr. Chair, and thank you, Madam President.
Thank you, Councilor Asabi-George. Councilor Baker.
Thank you. This was a good hearing tonight. As someone that has buried multiple people in my life, and also have revived people and have brought people to have sectioned people that I love, have driven people that I love to detoxes. Unfortunately, this is a disease, and it's been in my life my whole life. That's why I do this work here. It's why I care. There was one interesting point that was made by the last speaker. She had said that there was, in her count, 300 active drug users down there in that area, Mass and Cass, and 1,100 children. That's pretty scary, that the amount of time that we have to spend on the 300 people, that out of 300, 200 of them probably don't have Boston roots, don't come here, not that we don't care for them. But the reality is our resources are to speak to the money trail. Our resources are going towards people that are coming here because they're looking for housing and things like that. They're looking because of the successes that we have, the amount of services we have. But I think it's incumbent on us to try and, I would say that break up the services, but dilute them a little bit, spread them around the city a little bit. What does that look like? I don't exactly know, but mostly want to just say that this was a good hearing. Let's not take Section 35 off the table. I think it's something worth looking at. I'm hoping to change some people's opinions on that. And the safe injection sites are very dangerous paths to go down. Those are my 2 points I wanted to make there. And thank you again. Thank you, Mr. Chair. That was a good hearing. And good night, everybody.
Thank you, Councilor Baker. And I just want to thank our public advocates who waited to give testimony. I deeply appreciated them taking the time to make sure that they were heard here today. I want to thank our panelists. And I also want to thank my colleagues for being here and really dedicating themselves to the work and listening all the way through public comment and making sure that they didn't let anybody go unheard tonight. This is a complicated issue. It's a personal issue for many. I think, I don't know I've met anybody who hasn't had a direct family member who's struggled with addiction in some way, shape, or form. And it's also a potentially deadly one, and we are losing folks and it's urgent. And so when folks call it a public health crisis, it most certainly is. And I think part of the frustration that we have seen is that you have to utilize so many aspects. This really calls for a holistic approach to treatment, to centering folks, to getting work done. You need housing, you need treatment centers. In some cases, you need mental health centers, you need healthcare. You need all these different things sort of rowing in the same direction. And our systems aren't built to make that easily accessible to folks without means, really at all. And so we're trying to create systems that treat folks in the highest needs all at once. And I think part of the frustration that I've heard from both folks who called in, from folks who were speaking today, from colleagues, is that, you know, these systems weren't built to serve us this way. They weren't necessarily built to take in folks who have the highest needs and provide them with mental health treatment, housing, addiction treatment, especially when they don't have means. And so as we move forward, you know, I think it's really incumbent upon us to make sure that all of these parts of the sort of puzzle to what is a complicated issue are getting addressed equally. And so I thought this was a productive hearing just to get from the city where they are at this time and where sort of the deficiencies and the things that we don't have answers for yet are, because it tells us where the pressure points need to be. And, you know, certainly I know President Janey had a list of questions from the community and advocates. I have a list of questions. I forego a few rounds there so we could get to community comment earlier. I'm going to have those followed up on. Those will be public record. And I'll make sure that counselors, not just the counselors still here, but the council as a whole gets those answers when I get those answers so that we can share that with constituents. And so if anybody here still has questions, please send them to me. And for somebody who might see this later on any of the various ways that we share this, you have 48 hours to send in public comment. So please do. And you can send that, you know, I don't have it right in front of me. I believe it's, instead of giving you the
cc.publichealth.
There we go. It's cc.publichealth@boston.gov. But you can also go right to me directly at ricardoarroyo@boston.gov, even after that 48-hour period. So thank you, everybody, for your time today. With that, I'm going to adjourn this hearing.
Good night, y'all. Thank you. See you tomorrow, Kim. Mañana, te veo mañana. Oh my